potential to include them. There are many friends and colleagues and fans of Professor Albert Roton, God bless his soul, but we have restricted ourselves to the people they have really been very close to Professor Roton and interact with him academically and practically. And they were a major associate and scholars of him. This is how we made the selection of the speakers. And of course, the neuroanatomy members, we give them the chance, everybody to present, and whoever could present is included. The other warning, I gave it in the message, I'm sorry, so nobody will be offended, that we are going to time these presentations, a few 20 minutes for each. And we kept the comment and question toward the end, so we left, we can have 20 minutes or half an hour at the end for comments, so nobody will interrupt the flow by extended discussions or to fit the purpose of this. I hope this is understandable for everybody.
Ek, good to see you, man.
Yes, back on board.
Oh,
Where are you?
Good. I'm
Hi,
in
Biko.
Boston.
Okay.
Hi, Ahmad.
hi,
hear me?
hi.
Hi.
Yes. How are you?
Fine.
Doing
Oh,
fine, doing fine.
Professor Kobayashi, yeah. Now
Hi.
this time we caught you at civilized time. The other day
Yeah.
with the academy, it was, I think, 5 o'clock in the morning when you were waking up and saying hi.
Yeah, I just met you last
It was a tough timing
Yeah.
when it comes to the state. They start early in their time, but it was already afternoon for our time. All right, good to have you too. We have a few minutes before we start, and I was saying that we are going, unfortunately, time this presentation for 20 minutes and leave question comments toward the end of the sessions. If there is any leftover questions and stamina to ask questions after 3 hours marathon of talks. Eckhard, where are you now? Is in Boston or in Canada?
In Boston, yes. I made it
Oh,
down
you are
here.
back Bostonian. I see the dress and the tie. It's not the Canadian style.
Yes, I'll tell you more about it. We need to connect, but it's fantastic. I'm very happy and lots of good things to happen soon.
Wonderful. Good for you.
Pablo,
Hello, Ek.
my daughter is in Alicante right now. I need to figure out a way that she can connect with you.
Please do so.
I sent you a text later. She just took off yesterday spontaneously. I don't know how, but that would be awesome.
Please do so. Good to see you.
Yes, yes.
So, Pablo, are we able to put these things I asked about to put in the background, or
I send them to you by email.
Yeah, I'm trying to put in the background. I am not the very good person to put them in the background. So it
What
means
do you
I
mean
have
with
to
background?
leave
What do you mean with background?
just to show the pictures, just to show them. If I go,
You can open what I sent you and just share your screen.
but it means I have to leave that screen because this link is on my Gmail and that what you send is on the same mail. I'm worried that I leave and I will be out from the screen.
I don't catch you properly. What do you mean with background, Matt?
Not background, but we need to show these slides. If I want to show the slide by
If
shape,
you share your screen, we will see in the big screen your
yeah,
desktop.
I know the green button.
Niste osvetljen dobro. Tja vam bom dal laptop, tja.
A ja,
Tja, glejte sem. Tja, pejte.
aha.
Tja, pejte. Ja, da ste osvetljen lepo, ne?
Aha.
Yes, Matt. You going to try?
Yeah, I will try and see. You see, if I want now to check it out, it means I'm leaving the screen of the Zoom.
No worries about that. You just share your screen and open the file I sent you.
Ampak imam pa motil svetloba, če lahko
Or
malenkost.
the opposite. Open the file,
Yeah.
and when it's clearly in your screen, you can share it.
Let me see.
Ja, še malo.
Hello, everybody.
Hello, Victor.
Hi, Victor.
Super.
Hi, Victor. Sanjeev and Pablo, good to see you both.
Hello.
Hey, Victor.
Nice to see you.
Pablo,
How are you? Hi.
Hey,
Nice
Victor.
to see you.
Hey, Jack Marcos is also here. Jack Marcos. Jack.
Jack said.
Hey guys, I am just parking my car. I'll see you shortly on video.
Okay, no problem.
Okay, I thought you suddenly turned dark.
Only dark thoughts.
Pablo,
Yes.
I opened that slide you sent me. Now,
Yes.
when I want to go, I don't see the button for to share. Let me see.
It's on Zoom.
So, okay, let me see. Okay, you okay. Now I
Yes.
can click on it, and if okay.
If you find any difficulties, I do have it here already, just in case. But yes, we are just watching it. Yeah.
You see it, yeah?
Mm-hmm.
Okay, I think we will commence now with the opening the webinar. I have to excuse my colleague, Dr. Benish, Professor Benish. He has a procedure to do. He will join us shortly. And on behalf of the members of the World Federation Neuroanatomy Committee, I'd like to welcome all the faculties and speakers for accepting the invitation. And of course, welcome the audience from the worldwide, especially the young generation, to join us and to listen to the masters giving their presentation. This webinar is taught specifically to honor the greatest mentor and teacher and the master of microsurgical neuroanatomy of modern times, Professor Albert Roton. God bless his soul. He was a generous educator with no boundaries, and he was a teacher for all of us on this webinar and worldwide. I have to say his, I call it the holy book of cranial anatomy and surgical approaches, published by the Congress of Neurological Surgeons on behalf of Professor Roton's, a compilation of all the publication he did for the American Association and the Congress of Neurological Surgeons over the years from the 80s and 90s and 20s. And this became a Bible or a holy book for all of us, and it put him on the forefront of the education, international teaching education arena with this reference document. Needless to say, I can summarize the functionality of Professor Roton over the years. He is the most sought artist. We use his art on all our PowerPoint presentation. Nobody from us dealing with neurosurgery and want to present, he will not even skip 1 or 2 slides from the presentation related to the work of Professor Roton. And he is the most referred to actor to be on our visual rehearsal the night before surgery. We'll go back to his book, check that area we are dealing with, especially the complex anatomy there. He give you all the details. He give you his experience and how to approach in a safe and best outcome. And last but not least, I call him, he is the phantom of the operating theater, not the phantom of the opera, because he will provide you during the surgery, from what you have read about in these manuscripts, the best way to make a safe approach and give you the advice for maximizing a tumor resection with least complication. And this is what Professor Roton has done for us, and we cherish his the memory. I've seen him on several meetings, and the first meeting I met with him, I was a resident in Germany, Hanover, and he was invited as a speaker for the first skull-based meeting. And he started putting questions at the beginning of the presentation before he started. It was on aneurysm. And all the seniors could not answer the question he was putting because he was very meticulous with his question and very specific. So I learned from that day that Professor Roton is the man of knowledge in neuroanatomy and a great teacher. Without further ado, I'd like to welcome the moderator of the sessions. We moderated with Professor Atul Goel and Professor Pablo Gonzalez. Professor Atul is a known professor from Mumbai, India. He has his contribution in the field of cranioscervical in meningioma. And recently I heard him talking about the glioma and the dissection. And Professor Pablo Gonzalez is the emerging star of neuroanatomy and neurosurgery. And I expect him to be one of the leaders in that field with his own lab. So I will start as the first moderator with the first presentation. And I'd like to invite Professor Shigeki Kobayashi, a known figure for us in neurosurgery, in vascular and skull-based surgery. He has his greatest work he's from Japan, and he has the greatest collaboration with Professor Roton. He has published and he has chaired that special, I think, committee or society of Roton Society, and he has a major contribution to our webinar and to the world heritage of education and teaching. So, Professor Kobayashi, please, the venue is for you. Professor Kobayashi, you can share your screen.
Yes, I'm Matt. Thank you. I'm going to be with you.
Yes, we see it.
Yeah. My topics today is the Dr. Roton and the evolution of microneurosurgical anatomy. Dr. Roton, this is my calligraphy I wrote, meaning reverence for a great star in the sky. We'll respect this great man in heaven and continue to learn from him and his achievement. Briefly, his CV: graduated from Washington University School of Medicine, 1959. He had residency in neurosurgery at Columbia University and completing his residency at Washington University in Barnes Hospital under Professor Schwartz. You know, he was the editor of the Journal of Neurosurgery. Interestingly, he was once instructor of anatomy at Harvard Medical School. And he, at the end of his residency, he was given a one-year fellowship on neuroanatomy by NIH. He came to Mayo Clinic in 1966 as a staff neurosurgeon and was there for 6 years. During that time, I worked with him very fortunately. He left Mayo in 1972, went to University of Florida as professor and chair in neurosurgery. He worked there until his death, 2016. For me, he was can be characterized as, with these 5 names. 1, anatomist, microneurosurgical anatomist. He reported over 500 publications, including 160 original articles, and a great textbook, Roton. And this book has been translated into various languages, Chinese, Portuguese, and Japanese recently. Secondly, he is a neurosurgeon, staff neurosurgeon at the Mayo Clinic, very busy clinic, and also at the University of Florida Hospital, he was actively involved in surgery. Now, thirdly, he was the microsurgical instrument inventors. He organized the Third International Society for Neurosurgical Instrument Inventors in Las Vegas in 1995. This meeting was first organized by Sugita and myself in 1995 in Matsumoto City, in Nagoya City. And he has developed more than 200 devices and instruments for neurosurgery, the Roton tray. This meeting was held in different places over the world. He held this meeting in 1999 in Las Vegas, as I said. Dr. Roton, he was the dedicated teacher. He established cadaver dissection laboratory in 1975 in Gainesville, and he attended the numerous courses and seminars in the US and over the world. Publication, as I said, original papers and the treatise, Roton. As you know, WFNS organized the system of Roton collection available for neurosurgeons all over the world. Well, his contribution to Japanese neurosurgery. We first organized a neurosurgical anatomy seminar in 1986 with Dr. Roton as one of the guests, and we have done this 33 times annually and producing proceedings most of the time. The average attendance 700. Now, the Roton Society meeting internationally. This was held in 2018 in Tianjin under the name of the Roton Society meeting. These are the faculty members. Now, this meeting was preceded by similar international microneurosurgical anatomy symposium in different places in the world. First was organized in Matsumoto City, Japan, with Dr. Matsushima president and Dr. Roton as honorary president. Dr. Roton, humanist, humble, humanistic. Minute you meet Dr. Roton, he treated us very friendly, and he gave an impression we are being very important person. Now, so much for Dr. Roton, and I'll go over to talk on evolution of microneurosurgical anatomy. What is microneurosurgical anatomy? This is the topographic anatomy, fusion images of neural structures, vessels, cranium, the neural bone and membrane, the brain and spine. This is a roadmap for conducting an accurate and safe neurosurgery. This is to understand various approaches, to review them, and help create new approaches. Now, I'll go following these items about the history of microneurosurgical anatomy. Now, historical overview. Anatomy started in Greek areas, as you all know. Hippocrates, the father of medicine, and continued to the present time. Surgery, modern surgery started, was said to have started by Perret, French Roton surgeon, and continued to from surgery. Neurosurgery evolved in early 20th century, Cushing and Dandy. Now, I'd like to introduce the term surgical anatomy, which developed in the 18th century. I'll tell you that in a minute. Microsurgery developed from in early 20th century, and then from there evolved the microneurosurgery. Now, in Greek time, Hippocrates, he was the father of medicine, as I said. His anatomical knowledge was kind of superficial because it is from injured human. The first cadaver dissection was performed by Herophilus, Alexandria, and then famous Galen came on from Pergamon. He wrote an anatomy procedure book, anatomy procedures in 15 volumes. He was called father of anatomy. His anatomy knowledge was based on his monkey anatomy, but this anatomy is so good and it's remained uncontested until Vesalius in 16th century came on. At that time, however, the anatomy was not clinically purpose. It started as a field for scientific interest and pursuit. Now, the revival of cadaver dissection was done by surgeon by the name of Mondino, and human cadaver dissection was done. He wrote a book, first modern anatomy textbook. Then Andreas Vesalius came on 16th century, published very famous anatomy textbook, Fabrica, with numerous illustrations. And his knowledge on anatomy was mainly Galenus anatomy, but many human anatomy based on his cadaver dissections. Now, about the same time, Paré came on, French barber surgeon, army surgeon, is called father of surgery. He wrote a book in French, which helped spread anatomy surgery knowledge over entire Europe. Now, 17th, 18th century, anatomy gradually evolved. And anatomy and surgery developed reciprocally and interactively, and mainly surgeon performed anatomy. And anatomy developed with the new knowledge in other medical fields such as William Harvey, circulation theory, and also cerebral anatomy by Thomas Willis. And the education of surgery and anatomy are very, very popular at that time. And one of the pioneers of anatomy education was Cheseldin. Now, next, the history of surgical anatomy. Well, in 18th century, Belgian surgeon anatomist wrote a book, Surgical Anatomy. And this now then a Irish surgeon anatomist wrote a book, Surgical Anatomy. And he said, among all sciences, anatomy is the most indispensable necessity for surgical profession. And we should not forget the guy by the name of Bergeret. He wrote the Atlas of Human Anatomy and Surgery in 8 volumes. And 2 of the volumes is subtitled Surgical Anatomy. This is the combination of topographic anatomy and surgical anatomy. You see here, trepidation delineated, illustrated here. And some of the atlases are so delicate and minute, you could misunderstood, could easily misunderstood this maybe microneurosurgical anatomy, but it's not so. Bergeret's anatomy was essentially macroscopic anatomy as opposed to Roton microneurosurgical anatomy, which was surgery done under the operating microscope. Now, evolution of microneurosurgery. Just overview is the neurosurgery evolved from surgery, Cushing and Dandy, And microneurosurgery evolved from microsurgery in early part of the 20th century. Microsurgery pioneer, Nyden is the otologist. He operated on otitis media by monocular microscope. And this spread to otology, eye surgeon, plastic and orthopedic field, especially neurosurgery. Now, we all know Jacobson's turret succeeded in microvascular osmosis in dog. And in Vermont, they opened the microsurgical laboratory where Marlis Yashigil studied. And coming back to their own clinic, they did clinical microneurosurgery. Marlis, for instance, operated on craniopharyngioma. As you know, Yashigil succeeded in ECIC bypass in Zurich. This is the first microsurgical symposium in Cincinnati, 1971. And in addition to a neurosurgeon, other surgeons in other fields gathers too. You see Roton, Yashigil, Hardy, Janetta, Maris too, and from Japan, Dr. Kikuchi attended this meeting. Some of the pioneers in microneurosurgery, see, I said Donahue, Yashigil, ECIC bypass, Maris famous for bipolar coagulator, Hardy for pituitary adenoma, Mayfield folder, Sugita aneurysm creep, and Janetta microvascular decompression, so forth, just name a few. Microsurgical symposium, second time at the Cincinnati Convention Center in 1975. These are the faculty, including Donahue, Yashigil, my mentor, Sant, and Sugita there too. Then, evolution of microneurosurgical anatomy. When I was a resident at the Mayo Clinic, Dr. Sant invited Dr. Yashigil, and he gave us a talk in which I never forget his word. I studied anatomy in the laboratory whenever I had time. Dr. Yashigil wrote the microsurgery, 4 volumes, actually 6 volumes, of which 3 volumes are titled Microsurgical Anatomy.
Examples are dealing with acoustic neuroma, which is a tumor on the nerve of hearing, and it involves the facial nerve, which, if the facial nerve is lost, it leaves a disfiguring, facial sagging face with inability to close the eye and smile. And during my training in dealing with these tumors, I never saw a facial nerve preserved.
Well, he was initially interested in cranial, lower cranial nerve, and this may be the first paper in the entire series of microneurosurgical anatomy by Dr. Roton. I worked with him together with the professor anatomy by the name of Hollinshed. Now, I was so fortunate to work with him in his first stage, at dawn of the microsurgical anatomy. According to Dr. Matsushima, he classified into 5 stages of entire microneurosurgical anatomy by Dr. Roton. Basic anatomy, skull-based surgery, internal structure of the brain, and new advances, surgical approaches, and anatomy. Now, just going through the anatomy, history of anatomy, you see, there was a time when surgical anatomy was so popular and introduced among neurosurgeons and anatomists. Then we have now microneurosurgical anatomy. How about the future perspective? Well, we just continue on Roton concept. New imaging technologies may come, new surgical fields such as endoscopic surgery and the vascular surgery came on. We have to study on that. New anatomical field such as perforated tract has been studied. I'd like to tell you about the education by the use of computer graphics. Now, on the basis of many cadaver dissection photos, Kakizawa made the computer graphic of this trigeminal nerves and magnified it. You can see behind this nerve by rotating 180 degrees. 3D scanning of cadaver specimen. With this is a 3D model. It is dry, permanent, freely rotatable, very useful, and repeated usage is possible. Skull-based anatomy surgery. It can be easily, simply demonstrated to younger neurosurgeons. Dr. Kim provided this video. The brainstem, we wrote a paper about safety entry zone to the brainstem many years ago, but this you see here with a tumor lesion in situ, you can demonstrate by computer graphics in relation to the surrounding tract and structures. Cerebrovascular structures, you can see this in relation to other brain structures you see here. Well, together with remote knowledge and ongoing the imaging images and with the computer graphics, we can design new future operating theater, Cincinnati University design. So in summary, anatomy started in Greek ages, and anatomy and surgery reciprocally developed. And the concept of microneurosurgical anatomy originated in the 18th century under the name of surgical anatomy. And microsurgery flourishes, especially in neurosurgery. And CG, computer graphics, will be important for future microneurosurgical education. Thank you very much for your attention.
Thank you, Professor Kobayashi, for this wonderful journey through the history of neuroanatomy and with an update of the perspective. Very well prepared and designed. I think I will move to the next speakers, Professor Vinko Dolens, an stout neurosurgeon from Slovenia, from Ljubljana, the place I visited you when you were there and in the peak of your practice. And amazing how you made this small city very strong on the map of neurosurgery. Professor Dolens have made his reputation in the field of skull-based and vascular surgery. And he hates to be called the Cavernous sinus surgeon because he was the avant-garde in promoting that service in a place called Natushba, Don't Touch. He was one of the people he risked it and proved that this is a place you can enter in, and he has modified different approaches to this one. Professor Vinko?
Yes, thank you. They hear me? No, if they hear me.
Yeah.
Okay.
We hear you and we see this slide.
Okay. The title, I don't know if it is appropriate or not, but I'm sure that microsurgery of the extradural space and structures is inevitable now. Why? I was confronted with the problems at the lateral skull base dural border, which is not just one step more laterally, as many big names were convinced. There are new territories. And regions of critical conflicts we may be confronted are at the region of the anterior clinoid process, at the posterior clinoid process, cavernous sinus, and petrous bone. And for that reason, it was necessary to study in details paracellular ICA, cranial nerves, triangular entry areas, venous compartments of those regions. Anterior clinoid process presents space limitation. This was actually the trigger I was operating an aneurysm at this region and I could not fix it. Then I said, I have to get rid of this bony protrusion. I got a drill from dentist with terrible torque, and it was not diamond drill, it was cutting drill, so it was very dangerous, but useful to start the studies at the laboratory. And I was sure and convinced that anterior clinoid process, which is here at the border, is preventing us to get out from the intradural space to the extradural in the region of the anterior clinoid process and cavernous sinus and so on. Here you see the removed anterior clinoid process facing mucous membrane of the sphenoid sinus, and here over proximal ring around the carotid, you see the carotid in the cavernous sinus, and you see intradural space, because many neurosurgeons were famous and good, excellent in intradural anatomy, including, of course, Roton, Donaghy, Yashargil, Kersey, and so on. But no one was not actually studying extradural so far. And we were forced by the practical cases to go over, to be aware, to be familiar with the extradural, which is over this region, and intradural. So you can be safer in one side of the wall if you know what is going on the other side of the wall. And this is an example, an aneurysm, large, and you can only safely, I would like to underline, safely exclude it if you remove the anterior clinoid process. You gain space and you can preserve the carotid. So it's like here. You see intradural space and extradural. So we just need to cut the dura and then we can follow the carotid from extradural to the intradural. Another similar case where we remove the anterior clinoid process to be able and to get space to put the clips. In giant aneurysms like this, at the adjacent to the dura, you see it was 5 centimeters actually in diameter, and we were able to preserve the carotid and to remove the aneurysm. But thanks to the getting space. Anterior clinoid process varieties. My colleagues, they are calling it variety. There are different varieties, different connections of ACP to the base. Sometimes it forms the ring, the bony ring around the carotid. Sometimes it is hypertrophy of the anterior clinoid. Sometimes it is erosion, and sometimes it is pneumatized. So it is not all the same. The clinoid process is different. Here we see the giant and enlarged hypertrophic. It is not only to remove it and be happy, to remove it safely, not to damage the optic nerve, not to damage the carotid artery, which is underneath. And it is much more difficult as when the anterior cannulate is normal. And here you see the removal. Then you might be confronted with a situation like this where the anterior cannulate is missing. Why? Because there was a trigeminal neurinoma on the first branch of the trigeminal, which was compressing the over the bone, and the bone disappeared. Here it is normal. Why? If you are aware, if you are in command of the anatomy, and you know how the tumor spread, then you will understand why it is pushing the V1 and the third nerve against the floor, against the optic canal, against the other structures, and then you can safely remove it. The last variation is pneumatization of the anterior cannulate process, like here. And here you cannot bluntly remove the anterior cannulate process because you will create a tunnel, and then CSF fluid will get out of the nose. And my generation, we are still with the chip in our brain that the fistula is a severe and serious complication. Anterior cannulate process resection, extradural or intradural. This is an everlasting conflict, and I do not understand why. We somehow favor the extradural removal of the anterior cannulate process and visualizing the structures extradurally, the ICA loop, optic nerve, and proximal ring and lateral wall of the cavernous sinus. So when we remove it from extradural side, we prepare and provide enough space to go anteriorly to the pathology, either vascular or tumorous. And then it is much easier to deal with the pathology. Now we have to be aware of the cellar and paracellar compartments. And we have to keep in mind how is the position of the ICA intradurally, how is the position of ICA extradurally, how the coverings of the anterior cannulate process are continually running toward the lateral wall of the cella. And then we know what is on one side and what is on the other side. And we not only understand the anatomy, we can also understand the physiology, how the hormones from the pituitary gland are traveling along the venous flow through the fenestra to the cavernous sinus, and so may spread also the tumor, one or the other side. Internal carotid artery coursing throughout the skull base and control of blood flow through it. For this, we need to study the bony structures and the coverings and the structures of the cavernous sinus, and of course, both posterior and anterior cannulate, and then we can put the carotid in it. Here from the side, you see that the coursing is making loops, posterior, somewhere here lateral, here the medial, and here anterior. I don't orient myself enough with C4, C5, and so on. I prefer natural descriptions of the coursing of the carotid. And here is the illustrator who put very nicely, this is the petrous portion of the carotid. This is the intracavernous portion of the carotid. This is underclinoid portion, and then intradural. Intradural and this portion are horizontal. And this is very important to have this concept. Then you can put yourself imaginary inside the cavernous sinus, and you look around and you can see the structures around you. But you have to understand also that the skull-based ICA is not just running through the cavernous sinus. It is heading, it is looping, it is spinning. We have no time to go into this discussion. What looping means, what spinning means, spinning of the blood inside the carotid and causing the aneurysms or other physiological functions. Of course, when you go more laterally, then you, after removal of the anterior clinoid, you can study the course of third, the fourth, and the sixth nerve, which is inside the cavernous sinus, and also the sympathetic nerves. The fifth nerve is lifted over, away, and this is the lateral ring. So they are very, very precise, very definite, very firm anatomical frontiers or structures you can use for your orientation. For instance, here, when the cavernous sinus is completely open and the third, fourth, and fifth nerves are away, then you can follow the sixth nerve, which is adjacent to the carotid and which is always running laterally to the inferolateral trunk. So it helps you to orient yourself in the cavernous sinus, and in particular when this space is filled with the pathology. You can go further. We found at one specimen small aneurysm, and this opened was our eye opener, how the aneurysm grows and what does it cause. For instance, you can see here the sympathetic nerves. You can see here the sixth nerve coursing over. And what happens when it grows? It will grow, it will cause the sixth nerve palsy. And then the sympathetic nerves, when the pathology grows further, will be torn. And the symptomatology from the sixth nerve will disappear. And so I was able to understand what happened to this young girl. She was 16 when parents brought her to us. They said when she was 3, she had sixth nerve palsy. And then with very successful physiotherapy, it went away. No, it didn't. The sympathetic fibers were torn, and then the sixth nerve glide at the site of the tumor, and until 16 years, when the tumor grow further and compress the nerve, the physiotherapy was not effective anymore. Now, anterior clinoid process resection, regarding the varieties of it and according to the adjacent conflicting pathology, vascular or tumorous. Of course, we have to be aware what is underneath. It's easy to remove all this portion, but it is not so easy to go inside and along the cavernous sinus. But when you remove the sphenoid wing, when you remove the anterior clinoid from extradural space, you devascularize the tumor and you much easier remove later on the tumor. Of course, it also helps you in such big pathologies and you can remove it completely. Necessity of resection of the posterior clinoid process in surgery of the posterior clinoid process and upper clival meningiomas. When you remove this from other side, from extradural side, you can help a lot to the surgery and you can remove the posterior clinoid process meningioma completely. You see the brain is intact, the tumor is missing. Also, superior or upper clival meningioma can be removed completely, but only with the removal of the anterior clinoid process. This is a case, this aneurysm was treated with by endovascular people. They could not exclude it. I operated this case with Yashargil in his operating theater, and we were able, by gaining the space with removal of the anterior clinoid, to get nice approach to this part and then to resect the aneurysm and to fix it. So anterior clinoid is our obstruction while we are working in this region, either only intradurally or intradurally and extradurally. But to be sure that we can manage if something happened to the artery, we have to be prepared and we have to visualize the posterior loop of the ICA in the petrous bone behind the Gasserian ganglion and V3 and medially to the middle foramen spinosum. Of course, by knowing the anatomy at the anterior clinoid process, at the posterior clinoid process, at the apex of the pyramid, then we can control the blood flow through the carotid artery, and we can deal with this huge tumor and we can remove it. We see that this carotid is compressed, as you see here. But we have to understand that the tumor did interrupt also the adventitia. And if we go too far with peeling of the tumor from such an artery, we may cause rupture of the artery during surgery or after surgery, which is always very difficult or even catastrophic. We can also replace this diseased part, but you have to be sure that the short high flow graft will work. This is even more important when we have a no ACA1 on the site of the tumor. And you are forced to deal with the extradural structures. Here, with the cavernous sinus, when you have the aneurysm, which is inside it. And you have to know the anatomy. There is no escape. You cannot say, okay, I will fix it somehow. How you will fix it? Will you close the artery? But you can, with the knowledge of the anatomy, you can resect the aneurysm, you can reconstruct the artery in the cavernous sinus and intradurally. or this case, the cavernous sinus is completely filled with the vascular pathology, huge aneurysm. After reconstruction of it, then you have a normal or almost normal ICA and preserved ophthalmic. I hope that you will agree with me that this cannot be treated endovascularly. With all due respect to the endovascular treatment, but surgery should not be completely ruled out of vascular surgery. As here, we can only go in, we find the distal stump, we find the proximal stump, and then we put the graft in between. Or in cases of injury, you cannot also pull this nail with the endovascular technique. You have to go in and you have to reconstruct it, and then the flow is preserved. Tentorial edge and transition of the cranial nerves from intradural to extradural space. The dural ring, which is on the lateral side, and then continue to the tentorial edge, shows us what is inside, what is extradurally. And so you can follow very nicely the course of the third nerve, where it comes in, through the tentorial edge and then intradurally. And then also the fourth nerve, which is very close to the V1. And then we have these triangles. Apex of the petrous bone and the inner auditory canal with the 7th and 8th nerve. We are at the posterior side, on the right side, posterior side of the gasserion ganglion. We remove the petrous bone, we explore the ICA posterior loop, and then we drill further down toward the posterior fossa, and we are aware where the inner auditory canal is. We cut the dura on the posterior fossa side, and we open, and we are in the inner auditory canal, as was many years practiced by Japanese otorhinolaryngologist Shiobara. Resection of the apex of the pyramid and safe corridor from the middle cranial fossa to the posterior cranial fossa. This is important and useful at the tumors at this region. So we see here the drainage from the cavernous sinus. We see here the posterior loop of the ICA. We see here the superior petrous sinus, where the petrous vein is coming somewhere here, and here the other drainage. So, but we see here the free bone, and then we can enter this region from the posterior lateral side. We can enter this region, and we are posterior to the 5th nerve, anterior to the 7th and 8th, inner of the inner auditory canal. So, and here is the, where is this now? Where's the 6th nerve? Yeah. Don't. Here's the 6th nerve, you see, and you go through this corridor, as it is shown here. Superior petrous sinus. The 4th nerve is there. The 6th nerve is down here. So, and the apex of the petrous bone in front of the inner auditory canal and behind the petroclinoid ligament can be completely removed like this. And you are safe. And you come from the middle fossa to the posterior fossa. Now, petroclaval and Dorello's canal or space meningiomas, like this, when you go through the petrous bone, then you can remove this tumor completely. Like you can see here, bulging into the bones and here after surgery. But we are on the right side. This is V3. This is ICA posterior loop, Gasserion ganglion, and the fifth nerve, the root of the fifth nerve. We remove the tumor from posterior side, but the job is not yet finished. We have to, when we remove the apex, we can transpose the root of the fifth nerve posteriorly, and we come anteriorly to the fifth nerve, and then we can remove the tumor, and we visualize the brainstem, we visualize the origin of the sixth nerve, we follow the sixth nerve all the way to the cavernous sinus. Now the tumor is completely eradicated. But we have to be aware, again, through the anatomy studies, that the sixth nerve might not be just one fascicle. It might be composed from several fascicles. So you have to be aware of this. This is carotid underneath. Now we come to the most difficult and most tricky part, to the corridor to the basilar artery tip. Removing the sphenoid wing, anterior clinoid process, posterior clinoid process, and then through this trajectory coming down to the basilar artery tip. Why this is so important? If you go medially from the carotid, we are on the right side, optic nerve here, you see here the perforators, thalamus striates. If you push the carotid laterally, you stretch the perforators and they may occlude afterwards, and you will have a bleeding in the midbrain. But if you go laterally, you push the carotid medially, and then you relax the perforators. You visualize the PCP. ACP was here, is removed already. The third nerve is laterally. So you have all the structures in front of you. This is the specimen. Then you visualize the posterior clinoid process. You can remove this bone. Pituitary body is here. Intradural carotid here. Intradural, ICA in the cavernous sinus, and the third nerve here. You remove it from extradural side. And then you visualize the basilar artery and the bifurcation, and you have enough space to deal with vascular pathology or to deal with tumors. This is a case. Look, perforators are preserved. The patient is completely normal after surgery. I have to mention history a bit. Duke Sampson mentioned in his publication with Hodosh about the basilar tip aneurysms that they were aware of the possibility of removal of the posterior clinoid process, but they thought it was too dangerous. Then we were studying this, and we said, if we deal with this carefully, we may do it, and we did it. Leonard Mallis, I visited him in '82, and he said, I don't believe you. You cannot go into the cavernous sinus. But I showed him what I did and what we did in our lab and in the clinical practice. But 3 years later in Japan, when I was under attack again from good colleagues who didn't do these cases, he said, they asked me, how you do it? And Mary said, I will answer. And then he told the story, how he did not believe, and now he is able to remove much more tumors from the cavernous sinus. And finally, Yashargil, who wrote the foreword in my book from '89, was in the department when I was asked at his department to treat an aneurysm at basilar tip, and I said I cannot accept this case and I cannot operate without asking professor. And then professor came and he said, oh no, this aneurysm cannot be operated, only a fool can operate. And then he said, oh, just him, like me. The family was on the other side. He can operate it. And I said, Professor, why don't do it together? I will do the approach and you will do the aneurysm. So I did the removal of the anterior clinoid, posterior clinoid, and visualized the whole region. Then he continued and he fixed with ease the aneurysm. After surgery, I mean, already during the surgery, he said, you know, I did not believe to you, but now you convinced me.
Vinko, we are with the time.
Late, we are late, yes, just conclusion. Surgery, so-called surgery in the lab prior to central skull base, live, real surgery for me is a must. Thank you very much.
Thank you very much, Vinko. Great presentation. So we ask the next speaker is Professor Jack Marcos, a stout neurosurgeon from Miami, University of Miami. He is the director of skull base and the director of cerebrovascular surgery. He has a double professorship appointment with the ENT and the neurosurgeon, and he is the man talking about the inseparable twins. Jack? Professor Marcos?
Can you hear me now?
Yeah, we see your presentation and we hear your nice voice as well.
And not as nice as yours or as Vinko or Shige, and thank you very much for your masterful series that you've been putting together and bringing all these giants to teach everybody, and your audience numbers show it. So you and Vladimir, we all owe you a debt really for doing this. Wonderful to see you, Vinko and Shige and the rest of the speakers. So how do we honor Roton in 15 minutes? So I thought I'll talk about this topic, which was really very close to him. Skull base and cerebrovascular are really two animals of the same cloth. This is where Al was born, a cabin in Parvin, Kentucky. It is amazing that to go from there to having photos and instruments represent who you are. Very few neurosurgeons in the world today, you can put their work product without their name and recognize who they are. With Al Roton, you do and you did, exactly as Imad introduced him earlier. He was a wonderful family man, and this is his slide. who among you would write a slide like this? Microsurgical anatomy is delicate, faithful, awesome, accurate, gentle, and safe. Who among us uses words like this on a daily basis? Very few. He has introduced humanity into neurosurgery. Of course, I am not one of his immediate trainees, but I've been honored to be on the board of the Roton Society, which Shige was a president of, and now Matsushima. Just you can see the love of everybody that he has touched. He is really a child, a scientist, and a saint, all in one person. And just very few people are really like this, certainly among neurosurgeons. You want to list his qualities? I think I've chosen 10. You can read them for yourselves. And again, very rare to see that conglomerate of qualities in one person. When he died, I had just become president of the North American Society, and I wrote his eulogy, and it's published. If you're interested in seeing what my thoughts are about this unique man, you can look it up. It's back in 2016. Are cerebrovascular surgery and skull-base surgery inseparable twins because they want to be inseparable or because they have to? So I'm going to conclude my talk later by telling you it's because they have to. So these are two boxes. The yellow box is skull-based, the red box is vascular. You can see some of the names of neurosurgeons that chose to be vascular pure or skull-based pure, but the ones in the middle chose to be masters at both. Please notice the box of endonasal endoscopy. It crosses a little bit into vascular. Some endonasal endoscopists do vascular work. No pure endovascular neurosurgeon generally does skull-based work. It's a call of the anatomy. It is a symbiosis, vascular and skull-based. You can see all the intersecting circles, the disciplines that encroach on those, not encroach, that are symbiotic with those two disciplines. But my point today in the talk is that area number 2 is very important. Why? Because cerebrovascular helps skull base. Examples are ICA balloon test occlusion for tumors, pre-op tumor embolization, intra-op repair of injured arteries or veins during tumor resection, the microvascular skills that you acquire in dissecting, manipulating, and respecting the brain. The other way around as well. Skull base helps cerebrovascular. Why? Through the Roton's anatomy, appreciation of anatomy, surgical exposure. When do you need that much exposure? What is just enough? What is not enough? And what is truly unnecessary as an exposure? And then you have your toolbox of all the approaches in skull base to tailor to the vascular pathologies. And you know, when you think of vascular and skull base open surgeons, I mean, they are very similar in character, if they're not the same person. And these are some of the qualities that came to my mind thinking of, you know, the big masters in skull base and or cerebrovascular, stamina and creativity and mental focus and so much. So I will submit to you that they are inseparable. So the rest of the talk, I'm going to show you simply case examples of how vascular helps skull base and how skull base helps vascular. Anytime something is written in red, it's cerebrovascular, and it's in yellow, it's skull base. So let's show you an extreme transodontoid approach for basilar invagination with transposition of V3. This is a case irreducible. My spine colleagues, I'm not a spine person, told me that a posterior fusion would not fix this man. He was fixed and he had myelopathy. So I normally do these odontoidectomy endonasally, but his carotids were very close together at the nasopharynx. And we even did the laryngoscopy and documented that indeed you can see the carotids pulsating and almost kissing in the midline. So I decided that that's not safe to go endonasally. So here we are, left far lateral, exposed V3 segment, section C2 nerve root, dorsal ramus, expose the proximal V3, expose tip of C1. We are using a Colorado needle, drill the transverse process of C1, unlock the transverse process, cut the fascia over the VA, translocate V3 segment of the artery medially, you can see it here, then do lateral mass drilling of the also occiput C1 joint, and that takes you all the way to the odontoid, which we drilled and cut the contralateral transverse ligament, and that's and fusion of the patient, and we've relieved the myelopathy, and you can see the post-op bottom left, how far you can go with that transodontoid approach, the post-op on your right. So had I not been comfortable handling the vertebral artery, I could not have done this case, it's clear. Vinko has taught all of us how to handle the cavernous sinus, and Atul Goel is on the list here today, and Atul has the largest experience with operating on these horrific lesions, the cavernous sinus hemangiomas. And unless you know how to handle the vascular supply intraoperatively, you cannot do these cases. So here is clinoidectomy extradurally, and then the Dolink peeling of on top of the lesion. The biggest mistake would be to enter the lesion right now. You don't want to do that. You want to surround your enemy before you attack it, and be comfortable with the coagulation, mapping of the nerves in the cavernous sinus, coagulating, finding on purpose the carotid artery in the cavernous sinus. You can use a Doppler to do it. And then when you've done that and you have controlled the perimeter of your tumor, then you go intradurally, you coagulate. Look, the lesion is becoming blue because the blood supply is dying. Now the enemy is ready to be attacked. And then you will still have bleeding, but it will be very tolerable bleeding. By the time we finished, we're putting some Eviseal tissue sealant. Here is the cavernous sinus with the nerves working between all the triangles, again, that Vinko has taught us so many years ago. There is a post-op MRI, complete resection of those lesions. Sometimes you have to do cavernous sinus exenteration to deal with tumors, on purpose sacrifice some structures. Such an example is this unfortunate woman with a WHO grade 2 meningioma. Look at the list of surgeries she has had elsewhere and with me over the years, radiation, cyberknife, and within few months, she developed cavernous sinus ophthalmoparesis, third nerve, which you just saw. This tumor had grown like 4 times in 6 months. Look how it's enveloping the supraclinoid carotid, the cavernous carotid, the cavernous sinus invasion. Young woman, I told her, we've tried everything. I am going to exenterate your cavernous sinus. I'm going to resect your carotid artery, including the anterior choroidal artery. I am sure I will not be able to save it. I will unquestionably give you a stroke, but I think you're gonna die if I don't try it. Are you willing to go ahead? And she was. I am not gonna show you the entire surgery, but just to show you the handling of the cavernous carotid. It's easy here, of course. We're going in to sacrifice it, not to preserve it. We had done a balloon test occlusion, and it's a matter of, you can see the clips. So, you know, a skull-based surgeon needs to know how to handle aneurysm clips, needs to know how to handle carotid. Here is the ascending cavernous carotid. Very nice view of the sympathetic plexus around it, clipping it and so forth. Again, it's not, the details are not important. It's just the concept. So here I am now cutting. You can see the clip below M1 and A1 bifurcation, including a sacrifice of the anterior choroidal artery. But I did resect the tumor completely. I drilled the posterior clinoid. What I want to show you is the stroke that I knew I was going to give her at the end, a fat graft here. Here is post-op fat graft, and the stroke that she had is this. She, amazingly, she recovered within 4 months. This woman lived another 6 years and then died of another recurrence. But I think she would have died that year had I not done something like that. I want to catch up on time. So if you allow me, Imad, how many minutes do I have? I cannot hear you if you're...
You still have 10 minutes.
I have 10 minutes. Okay.
Yes.
Thank you. Injuring the carotid artery during transsphenoidal procedure. My team has done 2 of these over the last 20 years. I want to show you this one from 2013. Recurrent pituitary adenoma. You can see, look at the right carotid artery, rather medial. And during the endonasal approach, my very talented rhinologist decided to use the pineapple sonopet, which is really not meant for drilling the bone because it's meant for coring bone. And you will see in a second, as he uses it, the carotid will blow out in his face. This design is meant for thick bone. If you want to use, you can use the claw of the design, the claw tip, or you can use the diamond drill bit. But please don't use this. You see the carotid on your left? Unfortunately, disaster is about to hit. And it'll hit so hard, you actually won't see the injury because blood will fill the endoscope camera. There you go. You can't see anything. So what do you do? Of course, it's transsphenoidal. It's not intracranial. You pack it, and of course, torrential bleeding. The point is, I'm not showing you this just to show you exciting bleeding, but if you don't understand vascular and you're doing skull base, that's a problem. So we pack it, and we go to the angio suite. And I'm going to show you the team approach between the endonasal endoscopist and my colleague endovascular. The packing occluded the carotid. So you take the tower, the endoscopic tower on the left, you can see it. So as the rhinologist is removing the packing, my endovascular colleague, Ali Sultan, is advancing the coils. So it was like a ballet. Again, luckily, the patient tolerated this carotid artery sacrifice, and I took the patient back to the OR. You can see the carotid with the tail of coil sticking through the hole, and I completed the tumor resection. Cerebrovascular at the service of skull base. How do you handle veins in some skull base procedures? Well, when you injure veins, you need to try to repair them. This is an example of one of my residents opening a retrosigmoid on an acoustic neuroma and tearing the sigmoid sinus. You can see it with the drill. Well, don't give up on it. Don't just pack it. And you can, if you know how to suture a vein or an artery, you drill a little more and you repair the sigmoid sinus instead of starting an acoustic neuroma surgery with an occluded vein and causing cerebellar swelling. And of course, veins are much easier to suture than arteries. You can use the parachute technique, which is temporary packing. You put your loose running suture and then you pull the 2 ends like this and don't over tighten, and that's it. And that really simple. Another case of a recurrent jugular foramen schwannoma. During the redo, during the opening, again, the vein of Labé was torn. Look how the brain was bruised during the opening. And this is the vein of Labé. I come in and I'm trying to figure out, can I salvage this vein? I have 2 ends of vein of Labé. Don't bipolar it, suture it together, end to end. Luckily, I was able to have enough length to do it. Otherwise, I probably would have taken a small vein and grafted end to end. So reopening the vein, there you go. And then again, very simple matter to do an end-to-end anastomosis. Again, if you're not facile with these techniques and you're doing a complex skull-based surgery, how are you going to deal with this? So here you go. And then we proceed with the surgery after that, with the tumor resection. And this temporal lobe edema, I submit to you, would have been worse had I not repaired the vein of Labbé. Now, how does skull base help cerebrovascular? Many ways. I will absolutely not have time to discuss all of them. Aneurysms, as Vinko opened the door for these paraclinoid aneurysms. Yazargil himself said he had no idea how to clip them. This is one example. Dural AV fistula, brainstem cavernomas. I'm going to skip superior hypophyseal artery aneurysm clipping, which of course Vinko taught us how to have a view like this when you clip with a fenestrated clip after drilling the clinoid. How would you do that without understanding skull base? In the current days of endovascular, of course, basilar tip giant aneurysms like this one kept recurring, stent, coiled, recurred. It's like a malignant tumor. Came to me last year. What did I do? Transcavernous approach to clip it. This is, again, no time to show the whole thing, but this is an anterior clinoidectomy. What is it that we need to understand? We need to understand the anatomy of the cavernous sinus. Here I am peeling the oculomotor triangle. This is drilling the anterior clinoid, skeletonizing third nerve and fourth nerve, moving cutting the petroclinoid ligament, moving posteriorly. These steps we did not understand, again, until Vinko and of course Roton created as well the beautiful anatomy. Here is a posterior clinoid. You can see the ugly coiled aneurysm. And what I'm going to end up doing is cutting into the aneurysm and clip reconstructing, cutting through the coils, cutting the PCOM, which is in my way. Here is PCOM cutting. And I'm not going to show you the series of clips, but I ended up clipping it with a very good result. Here is the post-op angiogram. Couldn't have seen this without drilling the cavernous sinus. I think I should reach my conclusion. I'll skip several other cases to show brainstem cavernomas, doing far lateral approach, Kawase approach, and so forth. Some twins are meant to be separated, some are not. And I think skull base and cerebrovascular surgery are such. My conclusions about Roton: the Roton legacy is thriving around the globe with societies like the Roton Society. It is a self-generating cycle of mentorship to mastery and mastery to mentorship. It's art and surgical skill intertwined. Skull base and vascular are intertwined. And to the young people in the audience, there is no such thing as talent. Deliberate practice beats talent every time. Go to the lab, and go to courses. Thank you very much.
Thank you very much being on time, Jack. It's a wonderful presentation. We'll move to the next part. Professor Atul Goel, he joined us and he's going to moderate the next 4 speakers. I just want to give you a warning. We have to get Dr. Miguel Reyes in exchange with Dr. Sanjeeva, as he has a special urgent situation, has to leave earlier. Okay, thank you. Professor Atul is a known figure. I have introduced you earlier.
Yes, Imad, thank you very much for organizing this wonderful show in the memory of giants of all times in the world of neurosurgery. And after legendary figures like Professor Kobayashi and Professor Vinko Dolenz, and the most loved and most influential contemporary neurosurgeon, Dr. Jacques Marcos, we have now the younger brigade of neurosurgery coming into picture. And one of the most favorite of mine personally is Dr. Pablo. Pablo is a I'm not sure, Pablo, how old are you, but I think you are quite a young and dynamic neurosurgeon, and you are the star of modern Spanish neurosurgery and the world neurosurgery. And the most beautiful thing that Pablo has done is extensive and very extensive and solid anatomical work that he's introduced into his own field of neurosurgery that he keeps presenting, not only for younger neurosurgeons, but every neurosurgeon of the world. Pablo, I'm very happy to be introducing you, and I'm looking forward to your presentation. Pablo, please.
Professor Goel, I am very happy to get this fantastic introduction. Thank you so much. It's my privilege. Thank you, Imad, for always giving me the highest challenge to speak after 3 giants of neurosurgery. So I swear I will do my best in order to tribute Professor Roton. I didn't have the chance to stay with him, but I can tell you that this is something that is not a book. It's my best mate in the OR. So I'm very happy and privileged to be here today. So let me share my screen. You let me know if you can watch it and hear me properly. So my idea today is to try to give an overview about how we take advantage of anatomy, thanks to our great mentors, and how we can squeeze and combine the anatomy with technology and understand much better every single case in order to go for the best surgical result. And this is the paradigm I always try to follow. In neurosurgery, first of all, we have to understand neuroanatomy, because this is going to help us to create a perfect surgical planning, which is going to help us to optimize our surgical approaches and surgical results. So regarding surgical anatomy, we have to understand why do we do our incisions, how to deal with our soft tissues, dissection, bones, craniometric points and landmarks, fissures and canals, dural layers. You have already watched how our giant colleagues have explained us how to deal with these dural layers, fissures and canals in order to be successful, to get a successful result. Venous sinus is, we just watched it with Professor Morco's lecture, that it's very, very important to deal with the veins in scalp-based surgery. The neurovascular structures, mainly, most of them, we want to decompress them and alleviate neurological symptoms. And last but not least, deal with the brain, with the sulci, gyri, and obviously the white matter fiber tracts. So how we take advantage of this anatomy in order to choose the best approach based on it. So we should go through anatomical corridors, respect the surrounding structures, and perform an anatomic manipulation. And this is going to be helped by neuroanatomy understanding a tumor biology. We just saw it with Professor Morco's lecture that it's not the same strategy to deal with an hemangioma in the cavernous sinus than treating a meningioma, and finally performing an anatomic manipulation. And for this, we have to select a perfect approach and patient's positioning. So regarding the surgical approach, we have very important things in neurosurgery. And the surgical approach, the ideal one, should achieve a wide exposure, provide multiple dissection trajectories, minimize brain reduction, shorten the distance to the tumor, facilitate early tumor devascularization and tumor debulking or removal, and finally identify and decompress the healthy neurovascular structures. So let me introduce a few cases and to illustrate how I invest much more time on surgical planning than in the surgical procedure itself. So this is the first case. Is a 31-year-old lady. She came to our department a couple of months ago, and she's a pharmacy employer. And she came with seizures that were well controlled after anti-epileptic drugs. So this is the image we have in our mind, and then we have to apply our surgical anatomy. So this looks like to be a frontal lobe tumor in the left side. It's occupying F1, completely partially invading F2, and we can see that the cingulate sulcus and cingulate gyrus are completely free of tumor. However, we can see that the tumor is surrounding the cingulate gyrus and invading the corpus callosum on the ipsilateral side. And if we do these two sagittal cuts, we will see that the tumor is just in front of the precentral sulcus, as we can see here. So it's a purely supplementary motor area tumor invading F2 also. So this is a 3D reconstruction that we want to have in our mind. And indeed, it's not a 3D reconstruction. This is the lab. So this is the anatomy we must be aware of. The tumor is invading F1, F2, and it's pushing posteriorly precentral gyrus. So this is probably the most important part of our resection. So this is the 3D reconstruction and functional MRI, in which we can see again the precentral gyrus relative location and the limits we want to create. So F2, precentral sulcus, interhemispheric fissure, and in the depth, we want to identify the cingulate sulcus. Once we go inside the brain, we must understand the 3D anatomy of these tracts. So this tract is the yellow one, is the corticospinal tract. You can see how close it is to the tumor in the posterior and deeper part. So this is something we must be really aware of. And we can see how the cingulate sulcus, it's protecting the tumor of its growing inside the cingulate gyrus. So this cingulate bundle is still preserved, despite the fact that the tumor is invading the corpus callosum. So surgical planning, once we have this anatomy in our mind, what we want to do is to expose the tumor, and also we want to expose the posterior third of F1, F2, and also the precentral gyrus in order to have direct control of the MEPs. So that's why we will, after the dural opening, check the N20 wave inversion and direct cortical stimulation to identify our functional limits. Resection, I usually start from anterior to posterior, or from the less eloquent area to the more eloquent one, in order to try to increase our surgical resection and stop around 3 to 5 milliamps motor cortical subcortical response. So let me do some commercials, and I really want to acknowledge a local company who is helping us with this kind of cases. So they are creating what we call very, very specific and customized 3D models in order to identify this anatomy and to prepare the surgery much better, in a much better way. So thank you so much for all your help. So this is the 3D modeling of this specific case in which we want to practice the surgery, and we do this with our residents from time to time in order to optimize our surgical approach. So this is the craniometric landmark we want to identify. This is brecma. So 4.5 centimeters behind, we will find the precentral gyrus in case of non-tumor case, but in this one probably it's a little bit more posterior. So these are the bar holes we are doing in the midline in order to expose the midline, because we want to have a look at the interhemispheric fissure at the end of the resection and to have more control of the lateral presentation on the motor strip. So opening the dura towards the sinus, and then we expose the tumor. Next step is cortical stimulation, as said before. Then we take a sample, we check the location of that sample, and then we start debulking from the less eloquent area to the most delicate one. So in the depth, we want to identify cingulate sulcus with the callosomarginal arteries. And then this is the functional resection. We are checking that we are quite close to the corticospinal tract. So that's the moment in which we will want to stop our surgery. And let's go to the OR right now and do exactly the same surgery. So we are opening the dura towards the midline. We are placing our flat electrode on the precentral gyrus. We check the point in which we want to take the first biopsy to analyze it. It was a low-grade glioma. This is how it came to us, probably an oligodendroglioma, which finally was. We do our subpial exposure. We try to preserve as much as we can the vascularization of these areas, at least till we are completely sure that we are far away from the cortical spinal tract. And then we move to the most posterior part, working in between the veins in order to preserve the draining of the surrounding areas. So this is the last part of the resection where we were identifying the corticospinal tract quite close. And this is the post-op in which we can see that the corticospinal tract was close in this point. So that's why we left a small part of this tumor in the most posterior part. But luckily, the arcuate fascicle and the cingulate were working properly. Let's move to case 2. This is a specific meningioma, which is probably growing in the sphenoid wing, and how we can differentiate a meningioma growing in the sphenoid wing from an anterior clinoid one. Generally, anterior clinoid meningiomas are growing upwards and lateral, but they don't used to invade the middle fossa. However, these sphenoid wing meningiomas, they can grow in any direction, but most of all of them will go to the middle fossa, pushing the temporal lobe, as this one is doing. And even some of them can even invade the cavernous sinus. So this is probably the more detailed classification of sphenoid wing meningiomas, where we can have different varieties of invasion. But in my mind, the most important thing is to individualize each case, and in this kind of tumors, to identify the relationship to the sphenoid wing, to identify the feeding behavior towards the brain, relationship to the optic nerve and the carotid artery and branches, and finally the relationship to the lateral wall of the cavernous sinus. So regarding the vascularization of this part of the dura in contact, close contact with the sphenoid wing, we have these 3 very important arteries: anterior branch of the middle meningeal artery, the lacrimal artery with these two important branches, which are crossing the bone in this area, crossing the sphenoid wing in this area. And finally, sometimes we have a recurrent superficial ophthalmic artery. In case of a big tumor, we can find this artery crossing the superior orbital fissure. So these are the 3 points we want to identify and try to drill and vascularize. So about exposure, pterional frontotemporal craniotomy, we want to perform an intense drilling of the sphenoid wing, because with this maneuver, we will create a space and vascularize this tumor before opening the dura. We will do a greater sphenoid wing dural peeling, and we can do, if we needed, an anterior cranioidectomy, as shown by Professor Doleng. Per section, we want to coagulate these feeders, which are mainly coming from the sphenoid wing, and also to coagulate the dural implant. So once we start opening the dura, we will do a basal opening and early central basal debulking, tumor dissection, and finally optic nerve and internal carotid artery decompression. So this is the general technique in which we can do our middle fossa peeling, trying to remove the clinoid and also to expose the lateral wall of the cavernous sinus. This is how we can do it in the lab. This is the sphenoid wing and the left side. We start our drilling, looking for the superior orbital fissure, where we will do our meningoorbital band, cutting the vascularizing. Already we will start the vascularizing our tumor in this step, and then do our peeling. So once we are doing this, we are keeping intact the lateral wall of the cavernous sinus. We will coagulate the meningoorbital band. So the amount of bleed, once we start doing our resection, will be minor. This is how we can continue the peeling in the lab. V1, V2, here we have trochlear nerve and the third nerve. So this is the anatomy we will gain. And these are the 3 points that we will have already devascularized: middle meningeal artery, lacrimal, and ophthalmic recurrent in case we have it. So if we reach this anterior clinoid, we will have completely vascularized the extracranial feeding of this tumor. So let's go to our model. We do our classic question mark incision. And with this model, we want to check how much we want to drill in this case. So we are planning our pterional craniotomy, doing our bar holes and the craniotomy. And this is the keyhole, which is very, very important. In this case, I want to expose the middle and anterior fossa and also the sphenoid wing. So this is how we can watch it, outer and inner. So this is the place in which we want to do our bar hole in that way. We will want to create more space in order to avoid brain herniation before we open the dura. And this is the extensive drilling of the sphenoid wing. We want to perform sphenoid wing drilling. We are devascularizing tumor. We are reaching the clinoid. In this model, we wanted to do a clinoidectomy. So this is the unroofing of the optic canal. This is the optic nerve. This is the third nerve. And this is the unroofing of the optic canal. This is the optic strut, which is the part of the clinoid, which will be the last one to be removed. And this is how we can devascularize extracranially and extradurally our tumor. So then we open the dura quite basal, start our decompression, and this is probably the most important maneuver, to dissect carefully with microscope the branches of the carotid artery. And here we do have a complete decompression of this structure. So let's go to the OR and try to replicate, if possible, the same maneuvers we have been planning for days and days. And this is our interfacial dissection. We want to increase our exposure of the anterolateral aspect. We are keeping always the periosseal layer in case we need it for reconstruction. Doing our bar holes, this is the keyhole. We always take a lot of care, especially in this sphenoid wing meningiomas. We'll complete our standard pterional craniotomy, and then we will start an intensive drilling. So once we start the drilling, we can see that we have a massive bleeding in this sphenoid wing. That's because it's feeding, these branches crossing the sphenoid wing are feeding this meningioma. So during this drilling, we see these big canals, and we start to vascularize properly our meningioma. This is the dural peeling. In this case, this is not so easy because the dura is infiltrated, so it's a little bit more difficult. This is the lateral wall of the cavernous sinus. Once we reach it, we are happy, and we keep going with our sphenoid wing drilling. We didn't need to go for the clinoid in this case because it was a sphenoid wing meningioma. We decided not to do that. So once we reached the roof of the optic canal, we kept going with our devascularization. We opened the dura, and then the tumor is much more gently. It's not bleeding so much, so we can keep going with our debulking of this tumor, and finally dissecting it from the surrounding areas and getting a good decompression of the optic nerve, carotid artery, and its branches. So let's move to case 3. This is a trigeminal schwannoma, which is quite capricious. It's invading Meckel's cave and also the posterior fossa. So the tumor, about the surgical anatomy, it's mainly growing in this area of the Meckel's cave, in close contact with Casserian ganglion and the posterior fossa. So this is the surgical anatomy as we see it. So we have tumors in this compartment and this other compartment. So we chose a subtemporal approach. And in this case of approaches, we want to take special care of the middle meningeal artery and V3. These are our landmarks in order to do the interdural dissection, as Professor Dolen has been explaining us. So we use these 2 landmarks in order to do so. So let's go to our 3D model and try to do this surgery. This is the question mark incision I usually do for a subtemporal exposure. We do a safe craniotomy. Then we try to reach the middle fossa floor. So we have to go as fast as possible. And then we start our dissection. That was B3. We can confirm it with the navigation. So this is foramen ovale. This is the middle meningeal artery. And this is where we start our interdural peeling. So the tumor starts appearing right here. This is the middle fossa compartment of the tumor. And after the interdural dissection, we can easily deal with this part of this trigeminal schwannoma. So this is what we are doing right now with the CUSA. But the tumor is going to the posterior fossa. And in this case, we decided to have a look. This is the protuberance, anterolateral aspect of the pons. This is the B3, this is the Casserian ganglion. So we are going to the posterior fossa compartment, and we can see this part of the tumor which is hidden behind the Casserian ganglion in close contact with the protuberance. So in this case, we decided to check how we could reach this hidden area through a Kawase drilling. So which is important, which areas are important, GSPN, V3, internal acoustic meatus, and superior petrosal sinus are the structures we want to identify to have a safe anterior petrosectomy in order to reach this posterior fossa compartment of this tumor. So this is the anterior petrosectomy we are doing in order to reach that hidden area. So this is Casserian ganglion again. This is the medially B3, GSPN right here. This is an internal acoustic meatus with the 7th and 8th nerve complex. And this drilling, this small drilling of the anterior petrous apex is enough in order to reach this area just above the 6th nerve and the ICA, which are right there. So now we are happy with the result. We are checking how the anatomy is normally positioned, and we can go to the OR in order to do our procedure with some maneuvers in our mind, which could be helpful in order to deal with this tumor in case we have any trouble. So again, same stuff, exposing posterior root of the zygoma for our bar hole. We do our craniotomy. We drill as much as necessary the middle fossa floor. This is the middle meningeal artery. So we cut it and coagulate it, or much better, coagulate it and cut it. In case the foramen spinosum is open, we can seal it with bone wax. This is B3, so this is foramen ovale. It means the tumor will start appearing right here as it was located in our model. So now we will start opening the capsule of that tumor. This is the petrous apex, the area we should drill in case we cannot deal with the posterior fossa compartment. But as you will see, luckily we were able to do it with a single subtemporal approach. So this is the Casserian ganglion, which was severely compressed. As you can see, this is a cotonoid protecting it and creating the plane of cleavage. So finally, we were able to gently take it out, and it was coming from the posterior fossa, and we were sure because that's the protuberance, and we had some CSF coming towards us. This is the post-op MRI, and this is the last case, very short one I want to share with you, a left foramen magnum meningioma, which is growing mostly in the left side. So surgical anatomy, very relevant to know specifically which is the best site in order to approach this kind of tumors, and probably the best approach is the so-called enough lateral or far lateral approach, which is our surgical planning. So we want to have a lateral position. We do this skin incision, specific one, and muscles detachment, lateral suboccipital craniotomy with C1 arch removal. And we will drill the occipital bone enough lateral in order to deal with the implant aspect of this tumor. So dural opening following the exposure in a lateral shape, and we will start doing the early vascular tumor devascularization with central debulking. So this is the skin incision in our model again. This sigmoid skin incision is quite helpful for us. So we do our barcodes in the asterion, mostly in the midline, and a third one located in between them to expose the transverse sinus in case we want to go up which was not completely necessary in this case, by the way. But for anatomical reasons, we decided to do a wide exposure. So we are drilling and skeletonizing the sigmoid sinus. And I'm showing now the same maneuvers in the surgery and in the model. So we are drilling C1 arc. We are getting enough lateral exposure. This is the drilling of the occipital margin of the foramen magnum, reaching the condyle, but not drilling it. We wanted to make sure that there was no need to do so. So with this opening, we expose the tumor, and now we are going to have a look at the CP angle to see how the nerves and the vertebral artery are pushed upwards in this case. So this is the pica. These are the lower cranial nerves, spinal accessory, right there. Here we do have the glossopharyngeal nerve and vagus nerve, right there, entering into the foramen jugulare. Here we do have the internal acoustic meatus with the 7 and 8 nerves, and upwards we have the trigeminal and 4th nerve. So this is the anatomy. We can have a look at the CP angle, and then we start the vascularization of the tumor, quite anterior, as much anterolateral as possible, in order to vascularize the tumor, as we can see in the surgical window. So here we do have the spinal accessory, which was over the tumor, and we were dissecting it posteriorly. And finally, once the tumor is completely devascularized, the surgery becomes much easier. It's a devascularized tumor, non-bleeding one. We can do our debulking and upwards dissecting of this tumor. And
Pablo,
this is yes.
One more minute, please, for you, my dear Pablo.
Thank you. I'm just almost done. So this is the patch we use. And this is the post-op CT scanning, which we saw there was no need to drill the condyle and a nice resection of the tumor. So just to conclude, and this is a famous sentence from Michelangelo, in which he said that every block of stone has a statue inside it, and it is the task of the sculptor to discover it. And he saw the angel in the marble and carved until he set him free. So this is what we should do with the skull base. This is our planning, and these are our tools. This is the operating theater, and we must perfectly master what's inside our marble. So this is the most important part of surgical planning, the neuroanatomy understanding. Nowadays, we have huge technology, and these devices can do our work. And technology reduces surgeons' fatigue, shortens surgical time, increases accuracy, and facilitates greater freshness when we are reaching the delicate areas. But there is something mandatory, and it's the 21st century artist, and this one is the one who should perfectly master surgical anatomy. So this is the basis. Then we can go for a safe pre-op planning, intraoperative technology understanding, and a delicate surgical technique. And there is no better artist than Professor Roton, so I thank him so much for all his efforts in order to create a great anatomical understanding for all of us. Thank you so much.
Thank you, Pablo, for that wonderful, wonderful, wonderful lecture. And it is a lesson not only for, it is indeed a lesson for every neurosurgeon that how you should prepare your case. These models that you are showing looks like a new innovation in the world of neurosurgery, and how to use models, how to use anatomy, and how to do surgery, and how to present with a smile. So fantastic, Pablo. Thank you very much. So we now move on to our next presenter, and that is Salman Sharif. And Salman is known quite widely, at least in our part of the world. And he is the president of World Spinal Column Society. He has been proponent. He has, with several of his webinars, he has promoted neurosurgery not only in his own country, but all entire region and maybe in the world. The most characteristic feature of Salman is his high academic work and his characteristic smile, like Pablo. His smile is also very characteristic. And I want to see that smile, Salman, and I want to see your presentation. Salman will talk today. Usually he talks on an endoscope in spine surgery, and probably for the first time, I'm seeing his talk on the cellular surgical anatomy. Salman, are you there?
I can't see Salman. Can you? Not sure Salman is in here.
So what should we do?
Shall I then?
I think we'll just move for the next year. Dr. Ramesh, perhaps are you ready?
Ramesh, you are ready with your presentation?
Yeah, I'll talk. Essentially, Salman called me yesterday and asked me if we could divide the talk into nasal anatomy and then stellar anatomy, which I was glad to. So he asked me not to go into the sphenoid sinus. So I said, that's fine.
Let me say a few words about you, Ramesh, if you allow me.
Please.
Ramesh is you have seen this popular face on this forum and in several other forums in the world of neurosurgery. Ramesh is consultant in skull-base surgery and in neurovascular surgery in Charing Cross Hospital and St. Mary Hospital, Imperial College Health Care and National Hospital Trust, and so many other things. So without spending much time in introducing this well-known name, Ramesh, please go ahead with your presentation.
Thank you, Prof. Goel, and thank you, everyone. As I mentioned, I was planning to talk on the endonasal anatomy, but then Salman also was talking on the stellar anatomy, so he asked me to limit my anatomy description up to the entry into the sphenoid sinus, which I was glad to. I'm going to start sharing my screen, and if you cannot see or anything, let me know. Hope you can see the slide. So I will be talking on this anatomy relevant to us neurosurgeons. So it's not an anatomy for the ENT surgeons, but what we should know as a neurosurgeon doing endonasal approaches. Mostly in my practice, I get the ENT team to do the approach for skull-base operation, either a standard pituitary or standard endonasal operation, or even for extended endonasal operation where you have to do extensive resections and extensive reconstruction. But the anatomy we need to know is fairly straightforward. What we need to know is that inside the nasal cavity, we have the midline nasal septum, which is constituted of a cartilaginous part in the anterior aspect of the nasal septum. And in the posterior part, you have the perpendicular pit of ethmoid, which is bony. And also, the other bones you come across, they are the vomer, and in the midline, the floor, the crust of the maxilla and the palatine bone. And then that is the medial aspect. And it is so an easy landmark once you go into the nasal cavity. Those who ENT surgeons, they are familiar with this anatomy because they do these operations in and out throughout the day for their functional nasal work. But for us, for skull-base approach, we also should need to know the relevant anatomy along this region. But the lateral aspect is more busy. You have more structures. It's very eventful, the lateral aspect. You have all the turbinates. Essentially, you have the floor of the nasal cavity here. If you approach it through the nose, then go along the floor, you go to the nasopharynx. And then you have the first turbinate. First structure you'll encounter, because it comes more anteriorly, is the inferior turbinate. And then slightly more posterior will be the middle turbinate, which is cut here to show the hidden structures behind the middle turbinate. And you have the superior turbinate. And these two turbinates, the superior turbinate and the middle turbinate, will lead you towards your sphenoid sinus. Because sphenoid sinus is, for us, once we are into the sphenoid sinus, because that's where we normally come into our operative part. That's why that the anatomy within the sphenoid sinus is what we are all familiar with. But to get into the sphenoid sinus, you need to know the anatomy, what the ENT surgeons normally use. So this anatomy is quite busy on the lateral wall. I'll come to it with some cadaver dissection. So this is the left side of the nostril. So sometimes it can be disorienting if you are seeing just the inside, because what you have to do is to look at the structures. In the medial aspect, you have a structure without any features. Unless you have like a nasal spur or a deviated nasal system, mostly it is a uniformly characterless septum. But on the lateral side, you have the turbinates. So you know that you are in the left nasal cavity. So you have the inferior turbinate here, where then more anteriorly you have the middle turbinate. And if you then go more forward into the nasal cavity and then displace the middle turbinate a bit more medially to expose the structures behind it, you can see the hiatus for the maxillary sinus, and you can see the ethmoidal bulla as well. But normally for our endonasal procedures, we go medial to the middle turbinate. So we don't really have to go laterally to it. unless you, in many procedures, when you have an extensive recession of the turbinates for a wider exposure, then you will be dealing with these structures. And what are the bony structures that's contained within the turbinates? You have the concha, the inferior nasal concha, and the middle concha. So these are all thin, spongy bone attached to the skull base. And we don't need to learn the intricate anatomy of this, because we often try to push it to one side or lateralize it or to resect it to get access to the sphenoid sinus. So I'll show you the anatomy which is relevant to our corridor. So it's important to balance it. The endoscope, which is a crucial instrument in these procedures. You can see that once we go into the nasal cavity, this is the left side nostril. I'm pushing the inferior turbinate. It's probably the ENT's colleague. So as the first thing you go there towards the floor of the nasal cavity into the corner. So clear up the corner. That is an excellent landmark for you to see the anterior wall of the sphenoid sinus. Your intention is to see the ostium of the sphenoid. So once you know the ostium, you don't have to have any worry at all. In the past old days, we used to get intraoperative X-rays for these sort of procedures. Nowadays, it's very rare to get intraoperative X-rays. Of course, we use navigation as a standard for most of these procedures, but it is not needed once you know where the landmarks are. So about 1.5 to 2 centimeter above the coronal arch, you will encounter. And it's customary for the ENT surgeons to use some patties soaked with adrenaline to decongest the turbinate, because they're all vascular structures. It's the less congestion you have, the better your exposure is. And so what is the anatomy here? So here you have just pushed the middle turbinate to one side with your instrument. You're seeing the front wall of the sphenoid sinus. You can just about to see the coronal arch here, and you can presume that behind these structures, this is the superior turbinate, and also something you can see a supreme concha or supreme turbinate. And behind it's hidden the sphenoid ostium. And sometimes this is called the sentinel of the sphenoid ostium. So in order to see it, you often will have to lateralize these structures or to remove it gently. Once you remove it, you'll encounter the sphenoid ostium. This is on the left side. The featureless, the nasal septum is here. And you have displaced the structures laterally to see it. So that anatomy is constant. Unless patients had a significant nasal surgery in the past, this anatomy is always there, and so there's no need to worry about the anatomy if you are attempting it on your own, but it's good to have an ENT support till you get some more exposure. So this is an intraoperative view of the middle turbinate, and also this is on the right side. You can see the nasal septum here, the middle turbinate here, and this is the corona. And this is the location where you have to be careful. In many procedures, even if you're not planning to do a big reconstruction with a septal flap, it's my practice to keep this area intact, because this is where you have this branch of the sphenopalatine artery supplying the nasal mucosa, septal mucosa. So beyond this, superior to this artery, you have the sphenoid sinus. So whenever you open up the sphenoid sinus, this is kept intact in both sides. This is what we call the rescue flap. And here again, the sphenoid ostium is well demarcated. So I'll show you the actual anatomy. So just follow the middle turbinate and displace it laterally. You see the superior turbinate coming in, then you directly go into the sphenoid sinus. So once you see the sphenoid sinus, it's important to make sure that you make it a bit wider. So because later on, before you enter it, if you cause that swelling and bleeding, sometimes you can again miss it. So first thing I do is to try and open up a bit more. So that you can see it more clearly. Then you can use any instrument, even a debrider, to debride this structure projecting in to obscure your view. And this on the right side, especially the superior corner, is where we keep our endoscope to park. So once we start the skull base operation, you need a place for the endoscope to park. So that's why you need to get some clearance on this corner. That is a standard practice. So here, this is the part I said, lower part of the sphenoid recess, where you have the anterior wall of sphenoid sinus. You need to displace it rather than cutting the mucosa here. The sphenopalatine artery is there. So I'm just going to, and once you see the sphenoid recess, you can, in the midline, you know that the crust of the vomer is there. On the other side, you have the sphenoid ostium as well. Here, you can see the crust of the vomer and the mucus of the sphenoid sinus. So this is how we see it normally. You have to get the anterior wall of the sphenoid sinus resected to get into the sphenoid sinus. Again, the ENT surgeons are often very fond of this instrument called circular punch, which is used to expand the sphenoid opening bilaterally. Then what you need to do is to connect the two sides. So what is happening here? This is the right side, the septum is here, and this is the left side. This is the lateral wall. Here you don't see this ostium, but you see a structure protruding through it. So these are some variation you have to expect. This is a polyp, which can be easily resected with a debrider to get a good view into the sphenoid sinus. So this is the expansion you're seeing. So you get a good view. So you have two openings. All you need to do is to connect these two structures in the midline. So in many cases where you do a larger opening, often you may have to resect the turbinate. This inferior turbinate on the right side, pushing it laterally. This is choana here. So this is the middle turbinate. This is blocking your view. And it is not an unusual thing to resect the turbinate in many cases. This is a technique to do it. So you don't have to cut it at the root of the middle turbinate. Once you cut it, you just need to push it down, all the way down, then gently peel it away and then cut it sharply, but not onto the wall, because you can then damage the vascular pedicle. So here it's cut and then it's gently pulled out. So that is all there is in terms of inferior turbinate. Here you can see the middle turbinate, and sometimes it can be used as a pre-mucosal graft. But in these days, when you have a bigger repair, if you don't use it, we use the nasal septal flap. So this bullae can be safely resected without any worry. And often we use a debrider. You can use a Kerrison punch, which is preference for many surgeons. I'll pass through the next stage. So again, expanding the lower part. I mentioned about making sure that the lower part is kept intact. So this is the inside the sphenoid sinus. So all you have is the median septum here. So this is again expanded bilaterally. So what is happening here? Once you expanded the ostium, you have to go to the other side. So I'm just opening the midline septum to see the middle of the sphenoid vomer, and then you go onto the other side as well, then connect it together. So here it's on the left side now. So I just opening up that. So this is a posterior aspect of the nasal septum. So all you need to do is to remove this part, and then you have a confluent opening on the sphenoid sinus. Then I go onto the right side again, and then cut this part of the nasal septum. So this is the middle, the vomer. The keel of the vomer is being taken out by a strong forceps, and which is the easy thing to do, and that gives you the complete orientation to the anterior sphenoid sinus. So once that is taken off, what you have left is the middle septum, which you can resect as much as you need to. Here, this is an instrument, it's called a backbiter. See this, we are on the left side, we're just resecting the lower part of the nasal septum, so that once you put the endoscope in more closer to your operative field, you don't have anything blocking the view from the other side. So this is the instrument which is used to resect it off. So this is from again on the right side, same instrument is being used to expand your opening. I'll just quickly go through so coming to the anatomy of the nasal flap, which is nasoseptal flap. It is supplied by the branch of the sphenopalatine artery which comes through the pedicle, which we mentioned in the previous slide about the rescue flap. The incision for the nasoseptal flap start from below the choana, just on the arch of the choana. You can come all the way down and then can carry it forward towards the floor of the nasal cavity, and in the upper part you go above the pedicle in line with the middle turbinate resection line, And you have to make sure that you don't go very superiorly more in the posterior part, because that's where the olfactory mucosa is there. But as you come forward, you can go up towards the skull base and get a wider flap. And this is a versatile flap, and it contains a strong vascular pedicle of the sphenopalatine artery which supplies the septum. This is a subperichondrial and subperiosteal flap, which is a very robust flap and is very versatile. And this is what it's like. You have the pedicle coming here, and you can, in the back, you don't go up to avoid damage to the olfactory mucosa here. And in the front, you can go all the way up to the skull base, depending on what you need. You can tailor it as you wish. And even you can cross onto the floor and onto the lateral wall to make it even more wider. So how do we do this? So once the incision is made, you can do it with a knife or with a monopolar fine cautery. Then you dissect it off from the nasal cartilage and the nasal bone. So this is a subperichondrial, subperiosteal lifting of the septum. So you need to detach the lower wall, lower aspect to detether it, and then also from the upper part you just dissect it off. Then once you dissect it off from the wall, you can store it in the corner so that you can keep it safe from your instruments and activities, so that you don't damage the pedicle there. So the pedicle will be right here. You detach it all the way down, push it all the way down. So then you can have a free access to your nasal cavity. Which side you do it, it depends on which is your preference. If you are using a right-handed person, you may want to do it on the left side, because all your drills and other instruments are often going through the left nasal cavity. So then you have the bony and the cartilage part of the nasal septum here. And it is easy to place as well. So when you place it back, you just rotate it over the anterior wall of the sphenoid sinus and then place it over the defect. This was like an invasive pituitary tumor with invasion into the cavernous sinus, which was resected with an exposed carotid artery inside the cavernous sinus. So even though there was no leak, this was used to repair just because the carotid was exposed. So, but then to get the flap to completely cover it, you have to detether it at the bottom so that you can pull it back. So now it is coming back to completely cover the your defect. There was an inlay Duragen graft as well. And then once you do it, you have to make sure that there's no twisting. So we used to mark on the surface with the methylene blue to identify the surface. Then you place it all around. And then we often, before putting some glue, we tend to cover it with some Surgicel as well. So this is the relevant anatomy for the neurosurgeons, and it is the more you do, you get familiarized with it. There's nothing worrying about it, because we deal with complex anatomy in the head all the time. So for neurosurgeon, this anatomy is sufficient. Thanks, Prof. Goel. Thank you very much.
Thank you, Ramesh, for that wonderful demonstration of the subtleties of anatomy of using endoscope to reach the sella and adjoining structures. And obviously, these are very important for those who are doing such surgery. So thank you very much. And I'm sure many young people in the audience, as you can see the numbers, must have learned several new things and must have rehearsed with you what they are doing. Thank you very much.
Thank you.
So we move on to our next star speaker, and that star speaker is none other than Miguel Arraiz. Miguel, you are there on the screen?
Yes, I
Miguel.
am, my dear.
Okay, so yes. Just to introduce Miguel, you can see this face, and you have seen this face often in the various webinars and in the various meetings and symposiums and teaching programs. And he has been a teacher par excellence. He has been a leader par excellence. And you will hear him now talking on chordomas. And I've heard him on several occasions, and I've loved hearing him. Thank you very much, Miguel. Let's hear what you have to say.
Thank you very much. Good afternoon, or good evening, or good morning, according to the place of the world. Thank you very much, my dear Atul, for the kind invitation and for your friendship. And well, let's start my presentation. That is, okay, I hope you can see my screen. Can you? Yes?
Yes, yes. Seeing the screen, seeing your face. Yeah.
Okay, thank you. So, well, regarding skull-based chordoma and how tumor anatomy and anatomy in general may influence on the surgical approach, I think that, I think that the microsurgery has been domainin the clival approaches for many decades, transcranial, transphenoidal, transfacial approach. Later on, endoscopy came, and since the very beginning, in the modern time of the transcranial approaches in the 80s and 90s, the anatomy was crucial. This is a case we operate on almost 30 years ago. This is a huge chordoma coming from the clivus as usual, growing toward posterior fossa, as you can see here. And this is the way we used to approach those cases. The extended subfrontal approach, popularized by Chandra Sen and Lakikam Sekar. And this is the way you had to very much know about the anatomy of the anterior fossa and the way you have to do bifrontal and bifrontal osteotomy, including ethmoidotomy, in order to have this view to first decompress both optic nerves. That is one of the frequent worries in cases with growing in the way we have seen in the MRI before, and then managing to drill the clivus under the microscope. And finally, fortunately, in that case, because of the anatomical disposition of the tumor in between both cavernous sinus and also the soft consistency, we managed to completely remove the lesion. You know that in chordoma is sometimes very difficult, not only for the invasion, but also for the behavior of the tumor. Sometimes soft suckable cases, very easy to be removed, sometimes infiltrative, hard and bloody tumor are really difficult. So also we did many cases of extended maxillotomy, open door maxillotomy, as popularized by Professor Crocker, and this is the way you can manage to remove lesion in this hourglass fashion, drilling the clivus and then removing the intradural component of the tumor. We need a lot of knowledge of anatomy, not only because of the tumor anatomy just beside and compressing brainstem, but also all the transfacial approaches are, of course, very much connected with the knowledge of anatomy. I like to mention Professor Eduardo Valencia, ENT colleague, who used to do the transfacial approach. This is the way we used to decompress brainstem, and after that, it was one of the types of reconstruction using a very big piece of fat, and then a spinal drainage, and sometimes lumboperitoneal shunt. And well, endoscopy came later on, and we just moved toward a different scenario. This is one case we faced maybe 13 years ago when we were at the 13 years ago when we were at the beginning of our era in endoscopy. This is a case that we managed to remove uninostril, two hands. That was the initial step of our learning curve. And fortunately managing to remove the lesion. I think that after Professor Ramesh Nair's wonderful lecture on anatomy and videos, we don't have to see that, we can skip the video. And this is the way we used to reconstruct at the beginning with the fat graft, old-fashioned. And this is another case that is giving us some memory of the initial case we see. Some lesion just compressing both optic nerves. You can see pituitary, hue growing toward posterior fossa, as you can see. Unfortunately, endoscopic approach able to remove the tumor from the macroscopic point of view completely. You know how difficult it is to see and to say that chordoma has been 100% removed. Also has been mentioned something about what we have to learn, and we have learned from anatomy. We saw the beautiful description of the nasoseptal flap, and this is the way we have to harvest it, and the way you can take advantage just to cover the inner surface of the sphenoidal sinus in order to prevent and to treat CSF leakage. Well, this is the way we have been accustomed. I think that since my beginning in skull base many years ago, when I was at the end of the training program, I've been witnessing many changes and the way we have been accustomed to different anatomies and different way of doing things. And talking about chordoma, when everything seems to be endoscopy, endoscopy is going to solve all the problems. This patient came, the patient couldn't be at the recumbent position due to difficulty to breathe. You see this case biopsy in another institution, a very non-satisfactory procedure for CPJ fixation, of course. And we have to keep in mind the let's say, big skull-based approaches. Keep in mind, apart from endoscopy, the high anterior cervical retropharyngeal approach that is very difficult, very easy to be done, and very straightforward for cases like this one. You can do this approach with ENT or by yourself. We used to work with ENT, and the way we in first stage remove the anterior foramen magnum abnormal infiltrated bone. Second stage, just replacing this not satisfactory fixation and also removing the posterior part of C2. As you can see here, modern techniques for fixation, we just completely remove, not en bloc in 2 stages, but we remove almost completely C2, and you can see some breakage of the hardware, but we wait for a while with a brace collar, and finally there was a fusion, but unfortunately, again, recurrency, another operation 2 years after, C2 complete replacement. This is not tumor, this is the iliac crest harvested just to be placed, substituting C2, and also fibular graft, trying to restore at least the stability at the CBJ, and this is the final result. But later on, again, recurrency 2 years after, you can see the lesion, again, recurrent, and in that case, distorting vertebral artery, and in this case, transcondylar approach. That is something any neurosurgeon loving and devoted to skull base has to domain. And this is another case. You can see this complex chordoma, sometimes it's like that. So you can see the extension here. You can see the posterior-inferior bilateral extension of the tumor. And if you look at the result of the endoscopic approach, you can see some pretty good result over here. But having a look to the axial view and coronal view, you have to see everything. You can see how, unfortunately, at least in our hands, very frequently, the most posterior, inferior, and lateral extension of the foramen magnum is left behind after endoscopy. So in cases like that, you need a complementary transcondylar approach. You can see the exposure of the vertebral artery, and you have to drill in the way we know, occipital bone and condyle. This is a real condylectomy. This is condyle infiltrated and removed. And this is a wonderful approach because you can domain the complete anterior foramen magnum, and very important part even of the contralateral aspect of the lateral inferior and posterior foramen magnum. This is in the context of surgical resection. And also you have to keep in mind techniques for CBJ stabilization that are far from initial drawings we saw at the second group, published in 1992. This is a unilateral fixation. In that case, just to C2 after removal of C1, partially in the context of the radicality of the lesion. This is another case. You can see this complex case. So upper and middle third of the clivus, irrespective of the intradural extension, can be more or less removed by means of endoscopic approach. But looking at this inferior, lateral and posterior component, in cases like this one, we do 2 stages. And according to the second one, this is after the first one, second one removed by a far lateral transcondylar approach. And in that case, the fixation in this patient, young patient, just making unilateral fixation, as you can see here, to the lateral mass of C1. And this is a pure lesion of the inferior third of the clivus and foramen magnum. For cases like this one, we have completely, we went back to the classical skull-based, open skull-based techniques, far lateral approach, transcondylar approach. You can see the lesion, you can see the extension, destroying the CBJ bony anatomy, and the way just going unilaterally, you can nicely remove the lesion. This is a postoperative MRI, and this is the postoperative axial view with a pretty good result. Also important to mention that endoscopy, of course, has to be kept in mind, and particularly for kids. This is a publication, 1996, of our very good friend Luis Porba and Professor Almefti, just concerning cranial chordoma in children. This is one of the cases. Look at the horizontal disposition of the clival area and also the lack of pneumatization, physiologically the lack of pneumatization of the sphenoidal sinus that makes a little more difficult the approach, but in any way you can, as you can see in that postoperative view, you can drill something like a tunnel and try to get inside. In that case, we left some part of the tumor inside cavernous sinus. The patient was sent to Roton beam therapy. Unfortunately, is under control maybe around 10 years after. This is another case of a young patient with 6 nerve palsy due to the invasion, as you can see here. And just, well, as you know, very frequently invasion of cavernous sinus is coming from outside, and following the tumor, you can get inside easily and you can remove the lesion much more than preoperatively expected. And you can see the immediate MRI with the tunnel, and you can see more or less the extension of the tumor and the lack of remaining tumor at cavernous sinus. And this is another case. This is a big lesion, but this lesion is not involving cavernous sinus, is not involving lower third of the clivus, nor foramen magnum. Fortunately, finally, the lesion was extradural, and by means of one single endoscopic shot, we managed to macroscopically and complete remove the tumor. This is a big piece of fat, and also the nasoseptal flap, as shown by Professor Ramesh-Ner. So, final consideration about the influence of anatomy on the surgical approach. First consideration, as we all know, revolutionary approaches are coming from endoscopy. Endoscopy came to stay, but endoscopy and microsurgery must be considered complementary techniques. And this second comment is mainly just addressed to the youngest colleagues in the audience. And going back to the issue of the influence of the anatomy of the tumor on the surgical approach, our current philosophy is just considering upper and middle third of the clival extension amenable for endoscopic approach, lower third and CBJ anatomy involved, more prone to classical open skull-based technique by means of lateral or transcondylar approach. So thank you very much. This is my last slide that is very important because I very much want to thank, first of all, my very good friend and brother, Professor Kanan and also Professor Benes, because they kindly have been inviting me and honoring me to take part to this wonderful webinar that has been an amazing example of the scope of education and transmission of knowledge. I'm very proud after having been taking part of this. And to the moderator, my very good friend Atul Goel, a big hug, and I hope we will have some coffee or tea very soon. Thank you very much.
Thank you, Miguel, for that wonderful experience. You have got several beautiful cases. You have got a big collection of chordomas, and I'm very happy to see your beautiful presentation, Miguel.
Thank you.
So without introducing Salman Sharif again, I will ask him to present his lecture on cellular anatomy. Salman, you are there on the screen? Salman, you are muted.
Right. I'm sorry, I just mixed up the time and I think it's my fault. I should have double checked. I think left it for my secretary who told me that time was starting at this time. So I really apologize for that, my fault. This is actually a picture of the book signed by Roton way back ago, about 10 years ago or so. And, you know, lots of things that I discussed with him at that time, the confusion that I had. He was such a simple anatomist. You know, everything he made simple. He never made anything complex. And, you know, even if you're trying to ask him difficult question, he'd answer in a very gentle way and very simple way. And I'm really grateful to Atul, obviously, for introducing me, and also to Imad and Bled for doing this day in, day out, every month, non-stop, and all of them wonderful talks. So I'm grateful. Well, this is just a coronal schematic section of the cavernous sinus and the pituitary. And we can see this is basic that we teach, what we teach to our residents when they're starting out, that the lateral wall obviously contains the nerves, except for the abducen nerve, which is lying very close to the carotid. And obviously pituitary is lying between the two cavernous sinus, which are extending from one clinoid process to the other, and all the way down to the petrous as well. And you can see that, you know, there's diaphragmatic sella covering it, except for where the infundibulum comes out. And the diaphragm sella really is the key to our anatomy in this particular area. Well, I'm going to be talking about basically taking you through how Roton thought the majority of the thing, and in the end, just briefly touch on how we can do this. I know that Ramesh has already talked about the surgical anatomy and surgical aspects, and I understood that the cavernous sinus would be discussed by Sanjeeva, so I'm not touching on those. Sphenoid bone is located in the center of the cranial base. We know this. The olfactory tract, the gyrus rectus, and the posterior part of the frontal lobe rest against the smooth upper surface of the lesser wing. Temporal lobe rests against the inner surface of the greater wing, and pons and mesencephalon lie posterior to the clavicle portion. The optic chiasm lies posterior to the chiasmatic sulcus, and we'll just go through this. So basically, we are seeing the body of the sphenoid, the lesser wing, the greater wing, and we can see the opening, the foramen rotundum, ovale, senior, and the lacerum as well, part of it. We can see the ethmoids in front, and the frontal, and the temporal, and the parietal posteriorly. So this is very important view. When I started out learning neuroanatomy, I think it was very difficult for me to understand this. Now it's become so simple with the 3D anatomy and our cadaver dissection. So greater wings are on both sides, lesser wing are on the top, and the body in the middle. And we have the optic opening in underneath a part of the lesser wing, whereas the superior orbital fissure is seen. At the same time, we have opening of foramen rotundum and the pterygoid canal that's seen as well. The two pterygoid plates are lying median lateral inferior to that. And if we see the anterior part, obviously, then we see the foramen rotundum here, the superior orbital fissure, and part of the optics is also seen. And obviously, this is the corpus is seen here, along with the two pterygoid plexus. Again, the ala minor and the ala major lying on both the sides. If you're seeing from the superior aspect of the sphenoid bone, the bone itself, then we can see that is jugum sphenoidale, and then we have obviously tuberculum sella, and the fossa hypophysalis is just behind that, and dorsum sella behind that. Obviously, dorsum sella continues into the two clinoid process posteriorly, whereas the tuberculum sella continues into the anterior clinoid process anteriorly. So, and if you look at an oblique angle, then you can see how from the lingula sphenoidalis, you've got this nice sulcus of carotid. So the whole carotid revolves around, turns around, and swivels its way and going to passing into the cavernous sinus. And from this oblique angle, you can also see the optic canal and part of the superior orbital fissure much clearly on the other side as well. What about the length and the width of the cella? This used to be important when we didn't have measurements scale and we used to measure ourselves. So cellar length normally 17 millimeters, cellar width 15 millimeter. The upper limit of the normal depth is 13 millimeter. The volume is usually calculated by, obviously, it's ellipsoid formula, so volume centimeter cube, which is length into width into depth in millimeters divided by 1,000. So that would give you the answer. And the total volume generally is about 1,100 millimeter. So here we are seeing a part of the optics on the right, which are tilted away. And then we can see the whole carotid taking its circle, turning its way. You can see the superior hypophyseal artery supplying part of the anterior lobe here. And at the same time, you can see the basilar on the other side, the carotid itself on the other side going underneath. And these superior hypophyseal arteries, the stalk is important when we are clearing out the pituitary tumor and making sure where exactly the stalk is. If knowing beforehand where exactly the gland is and where exactly the stalk is before surgery in any giant tumor makes life easier for you. And we have shown in a couple of studies that if you know that beforehand, then your outcome of saving the function is much higher. In this particular one, we can see that we have removed part of the dura above, and you can see the sphenoid seen above, the anterior lobe, which is lighter color above, and the posterior lobe below. And we can see the inferior hypophyseal artery turning and going into the posterior lobe itself. The curve of the carotid is seen again in the same way, and obviously this side it's covered. We can see the third cranial nerve going into the roof of the cavernous sinus, and the second and the carotid going underneath the falciform ligament. Pituitary gland, when exposed from above by opening the diaphragm, the superior surface of the posterior lobe of the pituitary gland is lighter in color than the anterior. The anterior lobe wraps around the lower part of the pituitary stalks to form the pars tuberalis, and the posterior lobe we know is softer, it's gelatinous, and more densely adherent to the cellar wall compared to anterior lobe, which is firmer and is easily separated from cellar wall. And we can see that when we are operating with endoscopy right next to the gland. So you can see that the gland itself, the anterior lobe, turns around, forms the pars tuberalis, and the color difference between the anterior and posterior lobe is very, very obvious. The sphenoid sinus is important for neurosurgeons. I'm sure Ramesh has touched on it. I actually spoke to him last night what he will do and what I will do. So sphenoid sinus separates the cavernous sinus, the cavernous segment of the carotid arteries, the optics, the third, fourth, and sixth, and branches of trigeminal nerve. And we saw that in the schematic diagram that I showed earlier. It separates the pituitary gland from the nasal cavity. It is present as minute cavities at birth, but its main development takes after puberty. So we need to know that if you're a kid, then obviously you'd have very, very small cavities and you'd have a conical type of sphenoid sinus. As age advances, the sinus frequently undergoes further enlargement associated with absorption of its bony walls. The types of sphenoid sinus in the adults depend on the extent to which the sphenoid bone is nematized. So
Salman, you have gone. You are frozen. We don't hear you. We see you dark light. Perhaps you have a interruption of electricity. Professor Atul, I'll try to message him shortly on the phone.
Salman, you're there? Salman? I think he has, we have
some
dropped connection, yeah. Maybe electricity failure.
I will send him a fast message and see if he responds. I think we just conclude his presentation. If he comes back, he will be part in the commentary and questions rather than to stagnate. So if you just conclude that part.
So we conclude this part of the session, and we now go to the next part, which is also very interesting. Pablo, will you please take over?
Sure, my pleasure. It's our great honor.
Yes, thanks Atul for moderating that session.
Thank you, Matt. Thank you.
So it's our great honor to have our next speaker, Professor William Caldwell. He's professor and chair of...
Sorry, just came back. There was a light outage. So I apologize for that.
Okay,
can I
so
continue from where we disappeared?
Imad,
okay.
you...
Yeah, go ahead. Go ahead.
Thank you. I apologize for that again. We talked about the 4 types of sphenoid sinus, the conical type in children, which is about 2% in general population. So precellar type, which is in which the air cavity does not penetrate beyond the vertical plane parallel to the anterior cellular wall. And the cellar type, which is the most common, is when the air cavities extend into the body of the sphenoid, but not beyond the cella itself, when it crosses the level of the cella and goes all the way posterior to the clivus, then it becomes postcellar. So this is what it looks like. So you can see all the 4 types, in which obviously depending on how much of pneumatization and how easy and difficult it is, and especially for kids, you need to plan this beforehand to know where exactly you're going to be drilling if you'd be drilling in that area. Again, it's important for us to know that how the sphenoid sinus is divided by septa, and this is our image guidance. So if the septa is lying in the midline, you know exactly where you're going to be entering. And there is a septa that is going slightly laterally. And then we know that about 1/4 of these go onto the side and be hitting the carotids. And then there are a small portion of these that may be just going and hitting the lateral wall. So this is image guidance for you. So this is for your planning of your surgery once you're inside operating endoscopically. Cavernous sinus, I was just going to touch it shortly. They are located on either side of the sphenoid sinus, cella, and pituitary. They extend from superior orbital fissure in front to the petrous apex behind and surrounds the horizontal portion of the carotid artery. The medial wall of the paired cavernous sinus form the lateral boundary of the cella. So we can see here that the dorsum is seen, pituitary is seen, the tuberculum in front. You have the anterior and the posterior clinoid process is there. And then you can see the oculomotor nerve going through a small cistern, entering into the roof of the cavernous sinus. And basically there's a triangle, oculomotor triangle, that is formed by a line drawn from the anterior to the posterior clinoid, and the oculomotor coming from behind. And you can see the basilar sinus, and obviously this all anatomy is important for us to understand before thinking if you're going to be going into that area. Falciform ligament is actually covering the optics and the carotid, and you've got the 3rd nerve here at the same time, the 2nd nerve here, and entering into the optic canal, and you've got the pituitary and the stalk, and the 4th nerve can be seen on both sides as well. I'm going to be showing the 6th nerve shortly as well. So here, what we have done is that we have taken away the dura covering the part of the cavernous sinus laterally, and at the same time, so what we are seeing is V1, V2, and V3 going there, and the sixth nerve going in through the Cavernous canal underneath. Here we have put in our Watson chain underneath the falciform ligament to show that if the decompression needs to be done anteriorly, how you're going to do that. And obviously for this, you need to be taking the anterior clinoid before you'd be decompressing. So here in this particular part, we have taken half of the covering, the right half, the covering is gone. So you can see the basilar sinus underneath. You can see that the sixth nerve is entering into the Dorillus canal over here, the fourth nerve running up, and at the same time, you have got the cavernous sinus running all the way, in which all these nerves are getting together and then going anteriorly through various foramens and entering into the optics itself. The anterior and posterior cavernous sinus can be seen here as well, along with the basilar sinus. So basically, petrosphenoid ligament covers, which is between petrous and sphenoid, which covers the superior surface of the Dorillus canal through which the sixth nerve is going through. Here in this particular diagram, we can also see that the extension of the basilar sinus on both sides, and also joining with the petrous on both sides as well. Here we can see the anterior clinoid has been removed, and we can see the optic strut just here. You have got the upper and the lower ring of the covering that goes around, and it's really thin. And this basically guides you anytime that you want to be decompressing in that particular area when you're taking out the clinoid. Here we have pushed the trigeminal nerves laterally, and the idea is to see the petrolingual ligament. And you can see that here in this particular diagram, we've got a nerve coming through, which we'll be showing shortly. Here, the sixth nerve, the whole course can be seen, along with fourth nerve also lying in the cavernous. So all of these are going through the cavernous sinus, as you can see from the opposite side as well. So one side is removed, which can clearly show all the exits of the nerves going through into the optics. The branches of the intercavernous portion of the carotid artery that supplies the cellar are meningohypophyseal trunks, the largest intercavernous branch, which gives rise to inferior hypophyseal artery, and meconal capsular arteries, which are sometimes present or not present. And here we can again see the greater petrosal nerve, at the same time joining together with the plexus around the vessel, and forming into a Vidian nerve. And you can now much clearly see the petrosphenoid ligament as well. At the same time, you can see the inferior hypophyseal artery again turning around from the carotid and supplying the posterior lobe of the pituitary. So the inferior hypophyseal artery arises from the meningohypophyseal trunk and passes medially to the posterior pituitary capsule and lobe, and anastomosis with its mates on the opposite side, and supplies the dura of the cellar floor as well. Meconal capsular arteries are frequently absent, and when present, they arise from the medial side of the carotid and pass to the capsule of the gland. So here in this particular diagram, we can see the meningohypophyseal artery arising and turning around, supplying the posterior lobe. You can see a lingula of the anterior lobe of the pituitary, a small lingula, and you can clearly see the second nerve going through, through the optic canal. The location of the nerves in the wall of the cavernous sinus, we have shown in a schematic diagram in here as well, from superior to inferior, third cranial nerve superiorly, trochlear, ophthalmic, and abducent nerves. The abducent nerve courses within the sinus on the medial wall, medial side of the ophthalmic nerves, the optic nerve, and is adherent to the carotid artery medially and the ophthalmic nerve laterally. The intercavernous venous connections are anterior and posterior. We know that, and the anterior one may be divided by either bipolar or by injecting glue into it if you want to be going into the plenum and doing any surgery on the plenum, extended surgeries. So a large venous connection, which we just showed you, is the basilar sinus, which passes posterior to the dorsum sella and upper clavis, connecting the posterior aspect of both cavernous sinus. The basilar sinus is the largest and the most constant intercavernous connection across the midline. The superior and inferior petrosal sinus join the basilar sinus on both sides. The abducent nerve, as we showed earlier as well, often enters the posterior part of the cavernous sinus by passing through the basilar sinus. And this is what we had shown earlier as well. So you've got the intercavernous sinus, the basilar sinus, the inferior hypophyseal artery shown here as well, and our sixth nerve trying to pass through the Dorinus canal after going through the basilar sinus. The diaphragmatic sella forms the roof of the sella turcica, and I had shown this earlier as well. It covers the pituitary gland except for a small central portion in the center, which transmits the pituitary stalk. The diaphragm is more rectangle than circular. It frequently is thin, tenacious structure that would be an adequate barrier for protecting the supracellular structures during transnodal operation. So you have to be careful because really thin and really tenacious structure. So this is where I thought that I talked to Ramesh that I'll take over, and he said that he'll talk about this bit of surgery. So now once we have gone in anteriorly and we have got the ethmoidal perpendicular plate in front, the vomer down here, we can see the sphenoid ostium on both sides. So we are approaching it anteriorly. The sphenoid mucosa is seen as well. You can see the optics above. And once we have taken all that bone away, obviously then we see the clivus, the carotid part, the clival part of the carotid hump we can see here, and we can clearly see the optics anteriorly and the sella itself. And this is exactly what you need to know when we are doing simple pituitary surgeries. Here we have taken out the covering over the pituitary gland, and now you can see that the sinus all around it can be clearly seen as well. Superior hypophyseal artery is coming from the top, and you can see the petrous segment of the carotid here as well very nicely. Obviously, if you want to be going laterally, then you can see the pterygopalatine ganglion as well, and the Vidian nerve on the opposite side as well. Let me just show the brief, let me just take you forward. So this patient had decreased vision for 10 months, just simple removal of keel. This is the tumor patient had. So once you have opened up, taken out the bone, use the Doppler to make sure there's no vessel underneath. Open the dura in triangle in the cruciate fashion and taking out tumor. And then ensuring that we have cleared it out completely over the tumor pituitary gland, which is lying right in front over there. And then we also did this study in which we looked at, along with our friends in Germany, that if you knew where exactly the gland was beforehand, and if you planned it beforehand and you saw the gland at the time of surgery, then the functional outcome is better in those patients compared to others. So it was really my pleasure to give a talk here. I apologize for the delay and the mishap there. Thank you, Imad. Thank you, everybody.
Thank you, Salman, for that presentation. I'm sure many young people in the audience must have got great information from your presentation and will take your message forward. Pablo, go ahead, my dear.
Okay, let's go. And again, it's my great privilege and pleasure to introduce next speaker, Professor William Caldwell. He's professor and chair at the Department of Neurosurgery in Utah. And he's the president of the World Academy of Neurological Surgery and the editor-in-chief of the Neurosurgical Focus. And he's going to be talking about combined approaches to complex skull-based lesions. Thank you for joining us and being here with us.
Well, thank you very much, Pablo. And I thank all my friends on the panel. It's been great to listen to some of the luminaries in our field. Shigi and Vinko this morning. And also I want to thank Imad and Vladimir Benish for putting this series together. It's a tremendous educational series, and congratulations on your success. So I thought I would talk a little bit about the problems that we have with skull-based surgery. And I think this case epitomizes it in that the skull-based tumors are rare and they're variable in size, location, and vascularity, etc. The approaches to the skull base are multiple. And it's not routine surgery. And I think it's much more difficult than most vascular surgery that we do, because it's many of these things like carotid endarterectomies and bypasses are quite standard. And these skull-based tumors are, everyone is unique and different. So I think the really issue that I'd like to address today are what is the extent of the tumor and what is the maximal capability of the approach that you choose to address the tumor. And I've really thought about this a lot, and I'll give you some examples of where I try to economize on approaches. Instead of using multiple approaches, try to optimize one major approach. And so with no further ado, I just also wanted to recognize Al Roton, who's obviously this seminar is in honor of. He's been a great mentor to all of us and a great educator and a surgeon and an innovator. And for many years, we taught courses every year with the WFNS with Al Roton until he got very senior. And at the end of his stint with the WFNS courses, Jeff Sorensen and John Robertson and I was the president of the WFNS at the time, we really convinced Dr. Roton to allow us to make this material open to the world. And he wanted it to be able to be available for everybody and to be used. And it was enhanced by Jeff. And so what Jeff has done is he's taken Dr. Roton's lectures and he's added this shading on the lectures and also on the library of images. So you can click on a particular nerve and it'll light up. It's an amazing contribution. And I think a biggest legacy of Dr. Roton in that he's left us with so much. And I can't think of one neurosurgeon that's left so much to his fellow neurosurgeons. So he also taught me that we should not be intimidated by the orbit. And I think we had mastered the cavernous sinus with Vinko Dolink in his era, beautiful surgery, masterfully done. And then it was an extension to go into the orbit. And these are all part of Roton's collection, but he describes all the 7 bones that make up the orbit, and then describes the intraorbital anatomy, which in many cases is really fairly simple. And I think we as neurosurgeons need to overcome our fear of going into the orbit. It's a very forgiving structure to operate on. The fat is a natural cushion for you. And the anatomy is quite simple. Here's the ophthalmic artery. And if you notice, most of the structures come from lateral and go medial. The ophthalmic artery, even the superior ophthalmic vein goes from lateral to medial. And 4 crosses 3 at the superior orbital fissure, and you just learned about that. And V1 comes up and the majority of the fibers are the supraorbital nerve here, and they sit on top of the levator and the superior rectus. And so it's a simple anatomical dissection to learn the approaches of the orbit. And we wrote a review on this, but basically you can distill it down into, I think, lateral and superior approaches will perform a lateral orbitotomy or superior orbitotomy for approaches to the orbit, or transcranial orbitotomy. And this is all a pathology that you can address. And the inferior aspect is very amenable to endoscopic techniques, inferior and medial. So I encourage you to read about this. I encourage neurosurgeons to be active in chasing disease into the orbit. And Al Roton was also the impetus for this development of this approach that we used, maybe a decade ago, a little lateral orbitotomy that gives access to the cavernous sinus. It's an extension of a standard ophthalmic approach that the eye doctors used to the lateral orbit for many years. And so you can extend it in the middle fossa, and we've done amygdalohippocamectomies now and lesions of the medial temporal lobe and tumors as well. Very, very interesting because you avoid retraction of the brain. Now, if you talk about tumors of the orbit, I think the biggest one that we actually undertreat is the sphenoorbital meningioma. And here's an extreme case, but these tumors involve the lateral sphenoid bone. They involve the orbit, they can involve the extracranial space, and they can involve, of course, the intradural space, and may extend back to the cavernous sinus as well. But the hyperostosis is the big issue. And that's often, it contributes a lot to the proptosis. And I evolved over the years with this, where I've become much more aggressive with treating these patients. And we use a radical bone removal of all the lateral orbit now. Now, usually, luckily, the tumor doesn't usually involve the orbital rim. So you can use this as your anatomical landmark and preserve this. It's important cosmetically. And then remove all the orbital roof as well. So you decompress the orbit completely, and then you can address the intraorbital tumor as well. And so I'll just show you that dramatic case, but I want to just show you the orbital part, because after we remove the tumor in the bone and in the anterior fossa and the middle cranial fossa, we'll remove the tumor in the orbit. And I think this is the most critical part. And this is what I've learned over the years, is that we can be very aggressive and remove the bone involving the periorbita and use the interface with the orbital fat as your plane of dissection. So you can extend back, you start anteriorly right behind the orbital rim, and you go right back to the orbital apex. And then you'll have to decide if the tumor is involving the muscles at all, whether you're going to remove the muscle or not. This one was not. Oftentimes they don't involve the muscle, and they may go right back to the region of the annulus of Zinn. But this is the kind of result you can expect on a case like this. Here's the pre-op and the post-op after 2 weeks. And here's, so it's a dramatic improvement, and we really need to help these patients with their vision. The other thing that Al Roton got me thinking about is economization of approaches. And here I'm going to show you a case where we're going to remove an optic nerve glioma with one stage. And the reason you can do this is because you can come in transcranial and go right out to the globe without any problems and use our standard retractors. In fact, it's easier for us to do it than the ophthalmologist. Traditionally, the ophthalmologists have come in anteriorly, and then the neurosurgeon has just cut the nerve posteriorly. But in this case, I'm going to show you a woman with a blind eye and an optic nerve glioma. And we'll do a one-stage removal of the optic nerve from the chiasm to the globe. And so standard approach, frontotemporal approach, meningorbital band, we'll take it down, we'll remove the clinoid and identify the optic canal and drill out the canal completely. We'll drill the superior orbit and remove the clinoid, and then you've got the optic nerve in its entirety in this clinoidal segment. And then after you've done that, then you go ahead and we'll go ahead and open the dura and then cut the nerve. I usually cut it about 1 or 2 millimeters anterior to the chiasm to avoid Willebrand's knee. And then the key to this operation is to not injure the fourth nerve when you open up the annulus of Zinn. So the fourth nerve runs over the optic nerve outside of the annulus of Zinn. So you identify the annulus of Zinn, you open it medially, and we'll open the orbit medial to the superior rectus, and there's the frontal branch of 5. And then you go ahead and you now dissect out the nerve all the way out to the orbit. And I'll show you how we do that. So we open up the annulus of Zinn and then identify the fourth nerve and stay on the nerve of the optic nerve. And you can see how thickened it is. It was previously biopsied here. And you can just use your retractors on the orbital fat and then walk right out to the region of the globe. And so we find the back of the globe. We'll amputate the tumor now at the globe and then remove the nerve. And how you do this is you lift it up and then you dissect it back completely towards the annulus of Zinn, and we'll pull it out from its investment within the annulus of Zinn. So there's the fourth nerve, the optic nerve, and we're going to be very careful when we remove the tumor so that we don't injure the fourth nerve. it's really cosmetic at this point because she has no vision in that nerve. There's the nasociliary nerve, and there we remove the entire specimen. So that preserves an approach through the face by doing it in one stage. So I want to talk about this case. Here's a 42-year-old woman with one of the worst meningiomas that I've ever seen. She has now difficulty with breathing. This is a woman who had craniospinal radiation when she was a child. You can see the tumors, multiple tumors in the face and in the cranium itself. The sphenoid, the nasal cavity is filled with tumor, and it's also down in her throat here. So obviously you need to use different approaches for this, but we'll try to economize and do the approaches that we can do naturally. And so what we'll do in this case is we'll start off transfacially. And so you've got this terrible tumor. This poor woman has really not had adequate treatment. So we'll start off transorally, and we'll remove the tumor transorally. Behind the palate there, you see we've split the palate, and we'll remove the remaining tumor behind there to open up her airway and help her with her breathing. Now, the next thing we do is come in transmaxillary, just above there, and remove the tumor within the maxillary sinus and back into the deep face. Next, we'll come in transnasally and remove the tumor in the nasopharynx and in the sphenoid. Standard transnasal approach, endoscopic, fairly straightforward. And then ultimately, we'll come back out and we've finished the transnasal approach. And then we'll do we'll bring her back for another stage, and we'll do the orbital tumor and the tumor in the lateral part in the infratemporal fossa. And that's what we're doing now on the other side of the head. So this is a different stage. We'll remove the tumor in the infratemporal fossa here. Watch the facial nerve. And then ultimately we'll go and do the orbital tumor as well. And here we are decompressing the orbit on the same side through the same incision. And there's the periorbital fat. And so ultimately we've reduced her proptosis, we've taken away her nasal obstruction, and we've also allowed her to breathe, and we can remove her tracheostomy. So I think that we need to think about economizing approaches. I'm going to show you this case. This is one of the worst acoustics. I think it's an acoustic. You can tell me.
Combined resection of a
But I'm going to let Richard Gurgel narrate this because I think it's a very interesting case. And it demonstrates the use of multiple posterior fossa approaches for a very complex schwannoma of the base of the skull. You can see what I mean is I thought it was a schwannoma because of its size and where its location. So I'm going to try and find her imaging. Here's her imaging. You can see it was 9 or 10 centimeters in largest dimension, and the temporal bone was completely eroded. So the hearing was still intact on the side, but reduced. So what approach would you use? If you do just a regular retro sig, you're going to leave all the tumor in the petrous bone. So we'll do a combined approach.
We begin by a piecemeal dissection.
This is retro sig.
Here using an ultrasonic aspirator to debulk the tumor. Large pieces of tumor we're able to remove initially. And as we approach the brainstem, we were able to see the 5th cranial nerve. Tumor dissection continues in a piecemeal fashion. Elevating the caudal lobe of the tumor exposed the lower cranial nerves, 9 and 10. Here we're removing tumor from the brainstem, and as you can see, this is a very vascular tumor. We've now drilled through the cochlea and are
so we're middle fossa.
Transotic approach. and identifying the facial
As
nerve
well.
in its more distal course near the labyrinthine segment.
So we're in the middle, we're in the temporal bone now.
Bone was removed medial to the fallopian bridge, and tumor was removed in this area as well. As we've drilled through the cochlea, we're now entering the petrous apex and the bone around the petrous apex, as well as the tumor within this space. This debulking and resection proceeded from multiple directions as we improved our access and exposure. And here we identify the fifth cranial nerve at the root entry zone of the brainstem. More tumors resected as we approach the jugular foramen. And here we're removing tumor that was adjacent to the lower cranial nerves. At this point, we've decided to abort resection of the posterior fossa. We obliterate the eustachian tube so that CSF cannot leak through the nose. Fat is used to fill the middle ear space and into the petrous apex on both sides of the fallopian bridge. We close the dura primarily in the posterior fossa behind the sigmoid. A temporary cranioplasty was performed. The skin was closed in a subcutaneous fashion and staples were applied on the skin surface. Postoperative imaging after the first stage identified where there was residual tumor and where our fat had been placed. There is still tumor in the This tumor was so large, there was a significant amount of tumor volume.
So we brought her
in all
back after a
locations.
week.
And here now we're getting a nice view of the fifth and sixth cranial nerves as we remove the cranial end of the tumor. Here under the tentorium, we're able to see very nicely the fifth cranial nerve in its entire course. The sixth cranial nerve is seen entering Dorello's canal. More bony exposure was required, now looking from the middle fossa approach with the temporal lobe elevated. We remove bone over the petrous apex with care to identify the carotid artery and other critical structures in this area. Additional tumor debulking was performed from the petrous apex. Here we're seeing the fallopian bridge and working medial to the facial nerve through our transtemporal approach. A large amount of tumor volume was still found in the floor of the petrous apex, and now we've been able to identify the internal carotid artery in its petrous segment. Of tumor dissection in that area. We now illustrate a clear view into the petrous apex with some residual tumor on the floor going through the jugular foramen. And here we remove the last portions of the tumor in the jugular foramen. Waxed off any residual air cells if fluid leak.
So this is her post-op
Postoperative
image.
imaging with this T1 post-contrast MRI shows complete tumor resection. There is some residual enhancement on the periphery, likely due to postoperative inflammation. A CT scan confirms this is Richard Gurgel at the University.
So I think that just gives you an example of how complex some of these tumors can be. And I just want to just emphasize, this point was already made by Miguel. When we're talking about chordomas in the lower part of the clivus, you know, it was our knee-jerk response to just do it transnasally, sometimes transorally if we did in the past, but it really got us thinking about whether we should economize the approach. This is a case in point, and it's similar to the case that Miguel showed, where we did an endonasal approach, and I won't show you the video, but we achieved only a canal out of the center of the tumor. The tumor was too fibrous, and so we had to add a far lateral approach. And in this particular case, I did a far lateral approach on one side, and then I waited a few months till the vocal cord improved on that side. And then I came back in on the other side to get the remaining part of the tumor. And it really made me think, is this necessary? And was the endonasal approach helpful at all? And in this case, I believe it was not. So we did this anatomical study and we published this approach, this transodontoid approach. I think Jacques showed a case this morning as well. And I don't want to waste time, but let me just show you this, how much you can get across, and you can go cross court into the other side of the head with this approach. And you can avoid actually bilateral far laterals. You can do it through one side. And you see the extent of this tumor. This is one of the worst chordomas that I've seen. And it went from carotid to carotid. And what we'll do here, and it's very similar to what Jacques showed, you have to mobilize the vertebral artery to get to the odontoid. Once you do that, it gives you a straight shot. We'll use image guidance for the bony anatomy. It's absolutely perfect for that. And then we'll try to do a supramaximal resection of the tumor. That means we drill all the involved bone. So we try to get beyond the margins of the tumor. So we'll drill out the clivus, we'll drill out the lateral mass of C1, the condyle, and find the odontoid. And so we're removing it from the left side here, and we'll go right over to the right side and remove all the tumor anterior to the brainstem. So once we get down and we remove the tumor, then we'll drill out the odontoid, which again is quite simple. Once you've got the corridor, once you've got the vertebral transposed, you can transpose as many levels down as you wish. You just have to drill out the respective foramen transversarium, and the vertebral can be mobilized. And here we'll clear the remaining chordoma off the anterior part of the upper cervical spine and the anterior brainstem. The key is to understand where the vascular structures are contralaterally, because you're deep. You have to know where you are with respect to the vertebral and also the carotid on the other side. So once we get the tumor removed, we'll drill out bone in a supramaximal fashion. We'll open dura in this case because I was not sure whether the dura was transgressed with tumor, and you can see there's a little piece of tumor in through the dura, and so we'll remove this area. And then we'll go ahead and close. And then obviously the patient needs a fusion as well. So we're drilling out the supramaximal bone, remove the tumor from the hypoglossal canal, and then we'll go ahead and fuse the patient at the end of the surgery, fat graft, and then fuse their spine. And this is what you have. So you can get contralaterally on both sides with doing this. So she was fused on postoperative day 5. And finally, I would just like to leave you with this caveat for the young people. These giant pituitary tumors are big and dangerous. And the reason they're dangerous is because if you do an incomplete removal, the remaining tumor can cause apoplexy. Here's a case in point where you've got this giant tumor. And again, I used to knee jerk, just go transnasally in the mall to start with. And I've changed that completely because I've thought about economy of approach and trying to control the mass of the tumor with the first surgery. And so here's what I did with every adjunct I could use, trying to put the tumor to come down. And you can see we've done okay. Maybe we've removed half to 2/3 of it, but we've still left a large part superiorly. And we had to come back in and do a transcortical removal. Now, what I do is I address the mass of the tumor with the initial approach to avoid the risk of postoperative apoplexy, which is up to 10% in these cases. And we've had a death with one of these cases because of that. So we'll come transcortically here. And I want to emphasize that if you plan their trajectory down the core of the tumor, the axis of the tumor, you can remove the tumor all the way down to the sella transcranially. Here it is, and you can see here's the stalk is remaining intact, and he never had a transnasal approach. And so you've got transcranial exposure of the sella. So in conclusion, orbital surgery is the new frontier, and I think we really need to use our skills and our knowledge set because our disease ends up in the orbit. We need to deal with that with confidence. And I think this multiple approach thing is an interesting topic. It may be necessary for complex skull-based tumors, but we try not to add an unnecessary approach. And I call this skull-based surgical economy. And I think you need to be familiar with the maximal limits of each approach to be able to maximize them. Combining approaches may be done simultaneously or in a staged manner. I prefer to start with the approach to remove the majority of the tumor, in most cases, the dominant approach. And multiple approaches can be done through the same incision, as I showed you on that giant vestibular schwannoma, where we use the transtemporal approaches, middle fossa, translab, transcochlear, and also retrosig. And then you need to, as Jacques emphasized this morning, a vascular experience for repair or replacement of arteries. If they do get injured, and they will on these big skull-based cases, image guidance and intraoperative monitoring. And I thank you very much.
Thank you, Professor, for sharing your experience and teaching us how to optimize the choice of the approach based on your expertise and the surgical anatomy. And in order to save time, as Professor Imad said, we will keep questions for the end. And let me introduce one of my good friends, Professor Sanjeeva Jayaretna. He's the skull-base surgery lead at Oxford University and member of WFNS Neuroanatomy Committee. And he's a very active skull-base surgeon, not only in the OR, but also in different training events. He's going to talk about anatomy for cavernous sinus surgery. Sanjeeva, so it's yours.
Pablo, thank you very much for that very kind invitation. And thank you very much to Glad and Imad for this very kind invitation. I really enjoyed the talk so far. Now, Imad was very clear with me that this should be anatomy rather than the operative side. So in a tribute to Professor Roton, most of my slides will be from that fantastic Roton collection that Bill just highlighted, the work he and Jeff Sorensen had done to get this available. And I would strongly recommend this collection to anyone interested in neurosurgery. It's just an absolutely fantastic archive of all of Roton's works. And most of my slides today as a tribute to Professor Roton or my talk on the anatomy will be based on that. So I'm going to cover some of the real basic anatomy. I know we have a lot of residents and students joining the webinars. So a lot of what I'll be talking about today is the basic anatomy. I'm going to start laterally, moving medially in until we get to the carotid. We'll take a view posteriorly, we'll take a view anteriorly of what the cavernous sinus looks like and talk a little bit of some of the principles when operating there. We'll talk about the sort of two major approaches. Most of that was really well covered, obviously, by Professor Dolenk, who really introduced us all to this field. And really everything you need to learn about operating there, you heard in Professor Dolenk's talk. And I'll just follow off the principle of what he said, where you have to understand what's next to you if you're going to operate here. I agree fully with Bill Codwell that we should all be operating in the orbit. I consider the posterior third of the orbit to be neurosurgical territory. And actually, I quite like coming down the medial orbit, either endoscopically or displacing the eye, or in very malignant tumors or fungal infections when there's an exenteration, an extension into the cavernous sinus. I think coming down the medial orbit is a fantastic approach into the cavernous sinus. But most of what I'm going to focus on today is that lateral approach, a very standard approach into the cavernous sinus. As we all know, it's this venous structure here, and I as a tumor surgeon, like to think of it as pockets. Venous pockets that you can work in, and then you can pack off as you remove tumor and work very safely to completely remove usually soft tumors in this location and protect the cranial nerves. And this, of course, is a beautiful aerial view. We're looking from the top down into the orbit, how the cranial nerves cross into the orbit. I'm not going to talk about, I'm going to stop at the suborbital fissure. Pablo has previously covered beautifully the anatomy in the orbit. I'm just going to focus here on the sort of basic anatomy in the cavernous sinus. As I said, everything you really need to know about operating there, you saw in Professor Dolenk's talk, which is beautiful. And my favorite approach, you've previously heard me talk about coming into the cavernous sinus posteriorly by cutting the tentorium and opening into Meckel's cave from the back. But today we're going to talk about the terional and sort of middle fossa approaches into the cavernous sinus. So whatever incision you'd like to use to get in a terional and down in the middle fossa. And then you have to understand that where either the suborbital fissure or at V2 or at V3, these are the locations where you can separate the dura propria, the meningeal dura from the periosteal dura, and you can then get beautiful access into the cavernous sinus. You've seen lots of videos today. Pablo had a very nice video as well, coming in at V3, which I think is when you're starting out, it's actually the easiest place to get into the cavernous sinus. So all you need to know about operating the cavernous sinus is understanding those two dural layers, and I'll show that schematic right at the end about separating between the dura propria and the periosteal dura and how that gets you beautifully in the cavernous sinus. But of course, once you're there, then there's a question about the pathology there and the anatomy of what you see in there. And I just want to go through that again. Salman covered some of it, and I just want to build a little bit on that. So these are the sort of things, and these are all cases I've operated on. where there's been extension to the cavernous sinus, and I don't necessarily always chase the tumor in some of these cases into the cavernous sinus. So I think soft tumors do really well. So this is a chordoma, and you can get a beautiful complete excision here, including of the cavernous components. So you have to understand how to come medially into the cavernous sinus. You have to, and get into that. But here's one where you would come laterally. This is a trigeminal schwannoma, small trigeminal schwannoma. I actually think the bigger ones are a bit easier. But how you separate at V3, protect V3, the patient should be neurologically intact in all of these cases at the end of the operation. And you can remove a trigeminal schwannoma nicely. This is another chondrosarc, and how it sort of does that quasi drilling for you in a lot of these cases. And you can just follow the tumor backwards. This is a cavernous hemangioma. This is a meningioma. Now, meningiomas are the one tumors I don't chase into the cavernous sinus. I think for me anyway, I think the outcomes are poor. But you have to understand there's going to be small remnants that are still inside. They're not always purely a lateral wall. And understanding the anatomy is important for that. And I favor just removing this sort of lateral component. Here's an example where it's gone forward. And again, I tend not to chase these petrous meningiomas into the cavernous sinus. So soft tumors, I would advocate trying to get a complete removal. I think it's safe. You can get it out nicely. Not so much in meningiomas. And that's just showing you can get small residual there, but you can get most of these cavernous tumors, cavernous hemangiomas outside. But the reason I put this slide in is you then have to understand what's truly within the cavernous sinus, like a cavernous hemangioma. You have to understand what is then in a sort of intermediate layer, like a trigeminal schwannoma, that has the nerves tend to have what some people refer to as this sort of inner layer around the nerves. And so then they're now between the dural layers, and these are probably the best ones to start with when you're starting operating the cavernous sinus, and actually very straightforward with good technique, very straightforward to remove. So you have inside, truly within the cavernous, then within the dural layers, and very straightforward to remove. And then tumors that are on the outer layer, and you can see how you can get very nice resections of these tumors, relatively straightforward to do. There'll be little bits within the cavernous sinus that I tend to leave, but everything on the outer layer of the dura you can remove. And then the final thing when it comes to cavernous sinus and understanding the blood supply, so this is obviously sphenoidal meningioma, some attachment of the clinoid and cavernous sinus, but I think really understanding the vascular anatomy, and very nice talk from Jack earlier, talking about why vascular is important for skull base and vice versa. But understanding that vascular anatomy, I think, is important. A lot of people feel maybe it's not, because the dura supply is going to end in the dura anyway, but I think it's actually really important. This is an incredibly vascular tumor. I think it's almost 6 centimeter tumor. Huge flow voids the size of the middle cerebral artery within the tumor, but you can safely take these out, I think, with a good understanding of the branches that supply this. It'll come from within the orbit and within the cavernous sinus, and that all comes from this basic anatomy of the cavernous sinus. You can get very, very complete resections, very, very safe resections. Patients do very well and are neurologically intact from having a good understanding of this anatomy. Okay, so let's start, and I'm going to use the Roton slides. As Bill said earlier, there's a fantastic resource in the Roton collection, which I would hugely recommend. I look at it all the time myself. I think it's just fantastic. So you have to understand, so we're looking at the right-hand side here. All of these are from the Roton collection. And as Professor Dolang said very nicely, if you're going to operate here, you have to understand what's next to you and what's next. So first of all, lateral view, looking into the right side of the cavernous sinus, brain obviously has been removed. Very simply, you first have to understand what the borders are. Okay, so you have to understand anterior clinoid process. You have to understand tentorial edge as the superior border. You have to understand, once the dura is removed, you see it better, superior orbital fissure going anteriorly. You have to understand inferiorly, there's Meckel's cave and the maxillary branch of the trigeminal nerve. And certainly laterally anyway, you've got the superior petrosal sinus posteriorly. You can see third nerve coming in. We'll see it better as we start to strip layers away into the roof. You can see the fourth nerve coming back posteriorly into the tent. And as skull-base surgeons, that's important for us. We routinely will cut the tentorium and all sorts of approaches either this way, coming anteriorly, or coming from the back posteriorly and cutting the tent, and understanding the superior petrosal sinus and the fourth nerve, and cutting behind it is very, very helpful. So that's that initial layer stripped away, and you start to see, in my view anyway, and of course if you've got very experienced surgeons here, Professor Doll and Professor Gold, they can tell us. But my view is that there are compartments in the cavernous sinus, at least definitely medial and laterally, and I think even more than that in the tumors, and that's what allows you to work nicely in these compartments, remove the tumor out. But we're starting to see that outer layer has been stripped away. You're now seeing a beautiful view of third nerve coming under the clinoid. Professor Doling showed some beautiful, we'll see some views with the clinoid removed, but just some beautiful intraoperative views of how removing that clinoid gives you fantastic access in. And that's definitely true for a lot of skull base and vascular work. But we're focusing on the anatomy here. You've got third nerve as it comes in, and you'll see as the clinoid, well, actually you can see probably better in the next picture, but one thing you start to see is this oculomotor cistern here. And so you can open from the edge of 10 if you wanted to the tip of the clinoid and chase tumors within this oculomotor cistern if you wanted to. There is a small area there which is very reasonable to go into and chase small amounts of tumor if that was going to give you a complete resection. Fourth nerve coming in, and then this sort of arachnoidal layer over the trigeminal ganglion, the various nerves. Ophthalmic veins and things will drain backwards here. You can see some of the drainage further back in the superior petrosal sinus. We'll remove the clinoid soon to look at the carotid, optic nerve, and clinoidal carotid. Just like taking that arachnoidal layer away again, you see that oculomotor cistern quite nicely that I talked about, where you can come in and start to chase tumors. You're starting to see the middle meningeal and the GSP end, marking where the carotid will be. Middle meningeal is really useful landmark when you're coming in middle fossa approaches to picking up V3, and I said V3 or the maxillary branch is a fantastic place and then enter into the cavernous sinus. And if you're starting cavernous sinus surgery, I think that's a really good place to start going for some of these soft tumors. Same view again, where we're just peeling back the layers now, and you're starting to see the course of the third and fourth nerves, and you're starting to get an idea of the carotid. We'll look at the carotid in more detail, and as Professor Dolek said, understanding the turns of the carotid, I think, are really, really helpful for surgical planning and what you're going to encounter when you're going to go into the cavernous sinus. We're just sort of slowly peeling layers, and now we're starting to see what 3 and 4 do, and we're starting to see the 6th nerve as well as it's medial to the ophthalmic division of the trigeminal nerve. Obviously, this is the maxillary division going to rotundum. I'm not going to talk about that today. I've spoken about that before, but you have to understand the anatomy here in rotundum, particularly coming endoscopically, and what happens in the tracheopalatine fossa, a lot of which nowadays we don't approach laterally. We would come endoscopically for that. Okay, so Salman touched a little bit on this, but this is now starting to piece together what we see laterally with what we see posteriorly. And here, an important structure here that what we see in a number of different approaches, and a lot of our complex endoscopic approaches we see in the CP angle, but you have to understand what the 6th nerve is doing. And there are 2 sort of important ligaments. We'll talk about the petrolingual ligament in a minute, but now we want to talk about petrosphenoid or Gruber's ligament. And that's very important to understand when you're sort of doing these sort of Kawase type approaches, this posterolateral triangle, and how the 6th nerve is coming over and its relationships to the basilar plexus and how it comes over the inferior petrosal sinus. So this is it just from different views. This is the view from the side, the view we've been looking at the whole time. You see the carotid there, that's 3, that's 4, V1, and you're seeing 6 medial to that. And you have to understand this, both when you look this way, you have to understand when you're doing posterior petrosectomies and things and you're coming the other way. And that's really important. So this view here is just pulling down the trigeminal nerve just to give you a better view of that. But this is the more important view here. So same view again. This is the petrosphenoid ligament. And you can see how the 6th nerve goes up. And you can see some of the posterior drainage coming out of the cavernous sinus there, and how the sixth nerve comes above the inferior petrosal sinus. So really important for you to understand how the sixth nerve goes back. You can see it's in relationship tighter to the carotid there, and that's important. Some of these tumors, usually when you're doing trigeminal schwannomas and things, you're very safe, you're protected by the trigeminal nerve. You definitely keep the trigeminal nerve intact in those operations, but you have to understand what structures are next when you're as you're taking the tumor off. Okay, and then maybe less so now in terms of the vascular work, but there has to be some understanding of the various triangles and the sort of entry zones that gives you into the cavernous sinus. And here the dissection has gone further. So before I talk about the triangles, you'll see what the medial borders are. With the sphenoid sinus, you're starting to see, including the floor of the sphenoid sinus, GSPN going forward, it's the vidian and how that relates to the carotid, and we'll look at that again when we look at the anterior view. The other important thing here, of course, is that we're now seeing the clinoidal segment of the carotid very nicely. So the enterocliner process has been removed. And that's the first triangle here. So you got the proximal and distal dural rings. And strictly speaking, if you're talking about the cavernous carotid, it's really between the petrolingual ligament up to the dural ring. And those are strict borders of the cavernous carotid. So if you're thinking about working strictly within the cavernous sinus, that's what you have to think of as your borders of the carotid. And the rest of it, obviously, is outside. You have the clinoidal carotid here, and that's was an important location. In Oxford, we moved a lot to endovascular treatment for a lot of open surgeons. That's still an important area, this sort of clinoidal triangle here giving you access to the carotid. And a lot of these triangles give you good access to the carotid, but also for some of these tumors into the cavernous sinus. So now we're looking at the next triangle here. That's between the third nerve, oculomotor, and the trochlea. So this is obviously the supratrochlear triangle. I'll show you another picture that shows the dorsal artery of the carotid coming off there. Coming below, you have the infratrochlear triangle, and then coming below here, you're starting to get your anteromedial, anterolateral. For me, I use this less now, these triangles, except for Kawase. I think it's been superseded by other approaches and other techniques, but still very important to understand the anteromedial, anterolateral triangles. This is between the ophthalmic and maxillary, then maxillary and between V2 and V3, V1 and V2, the triangles, maxillary and mandibular divisions. Then coming back, you've got posteromedial, posterolateral, and obviously posterolateral, hugely important. Kawase's triangle is GSPN that divides these two. You have to understand how the carotid lies. At this point, we'll look at the carotid in more detail. And this approach, beautiful approach into the posterior fossa. We've seen some really nice videos already shown today by a number of the other speakers, but fantastic. And for me, great views down to the level of the IAM. I know some people like to go further, but I think from middle fossa down to IAM, Kawase, absolutely fantastic approach, and we'll look at that in a bit more detail. So those are the triangles of access into the cavernous sinus. This is just another view. We're building towards the carotid now. So what we've done here is we've cut the trigeminal nerve out, and there's also been a drilling here in the posterolateral Kawase's quadrangle, really. So just to orientate you, we're seeing some new structures here. So firstly, of course, we've got the carotid. We'll talk about the carotid more once we remove more of these structures here. Third nerve coming in through the roof, fourth nerve coming back in through the tentorium, ophthalmic division, maxillary division going to rotundum, mandibular division going to ovale, foramen spinosum, and middle meningeal, key landmark that when you're coming middle fossa allows you to identify V3 and then get into cavernous sinus. And then once you've sort of separated out, then you can expose this posterolateral triangle. Here there's been some drilling into the cochlea, usually try and avoid that unless you really have to. But here you're looking into the IAM. So absolutely beautiful view of the seventh nerve. Superior petrosal sinus has been cut. You've got seventh nerve coming to geniculate ganglion as it turns backwards, gives GSPN going forward, which will join the deep petrosal nerve to become the vidian. And you've got the semicircular canals. And obviously, these are hugely important landmarks in the posterior putresectomy approaches and translab approaches, the IAM. But today we're talking about coming anteriorly and the anatomy coming anteriorly. Important to understand. Yeah, the sinus is here. Sorry, Pablo, do you?
1 more minute you have, sorry.
Better go a lot quicker then and skip forward. The other key landmark really to understand here is the petrolingual ligament and its relationship to foramen lacerum. Lacerum and things you can see very nicely on your CT scans. And so understanding the petrolingual ligament all the way to the dural ring, it's your cavernous carotid and its relationships here. And if you can operate in this area, that understanding is critical. It's just to show the major branches, meningo hypophyseal trunk. Another picture here of the infralateral trunk, which are the major branches coming off. Meningo hypophyseal is the key one to understand really for a lot of the skull base cases. Gives you the things like the dorsal or clival artery supplying the clivus here in the infratrochlear. This is just the venous drainage coming backwards, but the other important view then is to look anteriorly and get the same understanding anteriorly. So carotid is here, you've got vidian, you've got rotundum. I'll skip forward. I've highlighted, or actually the Roton collection has highlighted the clival carotid. And you should really understand how this is going towards rotundum, your sixth nerve, third nerve, and ophthalmic division all relate to that. And just a deeper view of sixth and the various nerves that we saw laterally, but now you're just seeing them medially, and you must understand both of that to operate on these tumors. That's just the Kawase again, and how you can understand the carotid and how tumors wrap around it is really important. You get very nice and very straightforward. I'll skip the video. Very easy to get once you understand that. Very straightforward resections. They're soft tumors, they come out very nicely. But if you're going to start on cavernous sinus surgery, this is a paper because I had a nice illustration of Professor Kawase, but described beautifully by Professor Dolenk, Professor Hakuba. You must understand the various layers. That is the key to doing these operations. V3 is the best place to do it. You have to understand that there is a periosteal and a meningeal layer and even an inner layer protecting the nerves. You can separate these layers. You can get in beautifully and easily debulk tumors involving that. It's a good place to start for cavernous sinus surgery. You saw some nice videos from my colleagues earlier showing some very, very nice operations in that area, but this is the key anatomy to understand for that. And then beyond that is the anatomy I showed earlier. This is just to show you can take these tumors out, patients are intact, you get complete resections. It's very nice, very straightforward. Okay, well, thank you very much.
Thank you, Sanjeeva, for this trip we had with you around the cavernous sinus. And last but not least, we are going to our last speaker, Professor Kasadi Kalangu, our good friend from Zimbabwe. He's the professor and chair of the department of the neurosurgery department in the University of Zimbabwe. He's a key member of different neurosurgical journals, editorial boards, and we are very happy to have him talking about anatomical consideration for bilateral approach to the foramen magnum. Kasadi, you can unmute yourself. Can you unmute yourself, Kasadi? We cannot hear you properly. We can see your screen. We cannot hear you.
Okay, can you hear me now?
Perfect.
Okay, let me put it in the mode of slideshow.
Yeah.
Okay, yeah, from the beginning. Perfect. Can you still hear me? Excellent.
Yes, we can hear you in your presentation.
Okay, thank you. Thank you very much for inviting me. It is a great honor. And thank you for the organizers. And this has been really well planned, and I enjoyed really all the lectures from other colleagues. Congratulations to them. And it is also a privilege to honor Professor Roton, because he's done a work which is tremendous. And this work has helped all surgeons and neurosurgeons in the world to understand better the anatomy and, of course, to treat patients safely. So he has, through his work, operated so many patients worldwide because of his work. I met him personally once in San Salvador, but he's a fantastic man, and I think everything has been said, but it's important to remember and to remind that. Okay. In fact, some of my slides are taken from his slides he made, and I've also borrowed some slides from Professor Campero so that I can explain these. Okay. So I'm going to talk the far lateral approach to the foramen magnum. As you can see, this is Professor Roton, and foramen magnum. It's a theoretically is a very straightforward operation, but on condition you know very well the anatomy and you know the landmarks. I'm going to try to show that, to demonstrate that. This is the typical MRI we can see, which is showing that we have a problem into the posterior into the foramen magnum. And how do we define where is the foramen magnum? Is basically the foramen magnum is divided, is separating the cranium from the upper part of the cervical spine. And anteriorly, you can see that is made by the lower 1/3 of the clivus and the posterior aspect of C1 and the dent or the odontoid dent. And posteriorly is made of C1 lamina and also the posterior part of the occiput. And from surgical point of view, you can see in this slide that which is showing the area where any pathology which is found on that green area is actually that pathology, showing that it is a pathology of the foramen magnum. Now, anatomically, that's the aim when you do your dissection, is to be able to identify those structures. It means the horizontal part of the vertebral artery. We can see the condyle just anteriorly. You can see the condyle just anteriorly. And in any way, I will go into detail later on so that we can see exactly what we want. It's just to show what we need. We need to attend that. The most important structure to find is actually this horizontal part of the vertebral artery. Now, usually, here again, we'll go into detail. It is on the triangle called the suboccipital triangle, which is made, I'm trying to get my arrow, which is not showing, yes, which is made here by the rectus posterior major muscle, the inferior oblique muscle, and the superior oblique muscle. And actually that part of the vertebral artery will be found in between here. And when we do further dissections, remove the fat tissue, you can see that you can here recognize again the structures, and we can see here the rectus posterior major, the inferior oblique muscle, and the superior oblique muscle. Okay. Here, what we see here is the rectus posterior minor. Here again, once you remove those muscles, you can see very well the artery, which is here. And below here, we have the inferior oblique muscle. Now, to get to that area, we have to expose 4 layers of muscles to get to the triangle, 4 layers of muscles. And as you can see here, the first layer is made by trapezius muscle you see here, and the sternocleidomastoid. That's the first here. That's the first layer. And you see that those muscles are inserting themselves to the linea nuchale superioris. And it's very important to know. The second layer is made by plinium muscle, which is also attached to the linea nucale superioris. The third layer, as you can see, is made by the semispinalis capitis and also attached to the superior linea nucale superioris. That constitute the first three layers. Now, the fourth layer, you can see, is made by this is what you see, rectus posterior minor, okay? Then it is made by the rectus posterior major, the inferior oblique muscle, and superior oblique muscles, which is very, very important, interesting, because in between then, that's where we find the vertebral artery. So this triangle is very important. You do all the dissections as soon as you can identify this triangle, because that's the one which is going to show you where is the vertebral artery. Can you still hear me?
Yes, perfectly, Kasadi.
Yes. Thank you very much. Okay. And this is the kind of incision I prefer, but you can do other incisions as well. As soon as you can identify that triangle, which is very, very important. And that's it, usually the incision. Once you dissect, you get now to the linea nucale superioris. And you see that on the linea nucale superioris, and you have the muscles which are still attached to the skin. That's very important. And when you do further dissection, you get down to the linea nucale inferioris, which is about 2 centimeters from the linea nucale superioris. And from here, you start to dissect, you leave the muscles to the cranium, and you start to dissect the skin until you get now you can see now the triangle we're talking about, which is the triangle here, because you know that in between, that's where you're going to find the vertebral artery. You see here the vertebral artery, and you see the posterior arch of C1. And when you do further dissections, you can see that when you remove the rectus posterior major and oblique superior, you can see now very well the posterior arch of, you can see the posterior arch of the C1, you can see the vertebral artery, and so you can see further there, but I'll show it much better in another slide, the condylus. You see here the condylar, and here this is the outline of the craniotomy, which will be done further later on. You see the craniotomy has been done. We can see here the occipital condylar. We can see here the vertebral artery, and of course we can see here the posterior meningeal artery. Now, the opening has to follow the medial limit of the sigmoid sinus and coming down, looking for my, okay, medial aspect of the sigmoid sinus coming down to the medulla and lateral to the medulla, so that you can expose very well this part of the area. As you can see here, once we've drilled the condylar, we have much more space. I will show that in another slide. Here we can see very well when the dura has been opened, we can see very well the posterior inferior cerebellar artery, which are, and then the medulla cervicalis. You can see very well. And this is, you can allow to have this space when you've drilled the condylar. Now, you'll hear, of course, in the literature that there is a debate between to approach the pathologies on this area, either on the retrocondylar approach or transcondylar approach. Generally, with the retrocondylar approach, there are those lesions which are lateral and also posterior. But those which are lateral and going anteriorly, it's better to go transcondylar because then you have more space to get there. Here, it is, the opening of both sides, craniotomies, just to show what happens. Here we still have the condyle. It means that you can do posterior condylar approach on this side for pathologies which are lateral but going posteriorly. So we can approach them quite easily. But on the side, you can see that you can go transcondylar, and we have the approach and the easy approach to lesions which are lateral, but also which are going anteriorly. Here showing again the lesion. The idea is once you have those lesions, the idea is to do an operation and remove them completely. And this is possible. I will show you later on. So here we have this is a drilling of the condylar aspect. You see here we have the horizontal part of the vertebral artery, and we are using actually the diamond part of the drilling, and one has to be very careful. There is quite a good distance between the two, between the vertebral artery and the part which is being drilled. One has to be just careful, and it is possible. Once you do that, and you drill that medial part of the condylar, you get quite a lot of space. And as you can see, once you open the dura, you can see the tumor here, just behind the arachnoid membrane. It's quite easy to spot. And once you remove the arachnoid membrane, you can see very well the tumor. And the trick now here is basically to gut the tumor, and progressively, what do? You gut the tumor, and progressively, you actually dissect it progressively from the surrounding structures. And you can do that without any problem. So here you can see the picture which is showing the area where the tumor was, and the tumor has been removed completely. And when you do the MRI, of course, you have removed completely the tumor. I hope I've gone straight to the point. And let's remember that the anatomical laboratory is the best place to learn surgery. I heard that from Professor Albert Roton. Thank you very much. I'm ready to answer all the questions. I tried to make it as simple as possible. Thank you very much.
Thank you so much, Casadi, for this comprehensive explanation about the far lateral approach. And let me thank also Andre Rotenhus and Takashi Kon for joining us. They have been here the whole session with us. We are now 4 hours together. And I will pass my word to Professor Kanan and Professor Benesh to conclude and open the discussion. Imad, Vladimir, you there?
Hey, Imad. Hi, Pablo.
Hello, Vladimir.
Hi, thank you very much. So the session was a long session, aren't they? Thanks, Professor Casadi, for your nice presentation as well. Now we have 15 minutes to 20 minutes. We'll try to cut it short. We'll try to minimize the comment unless it's necessary. I might start with this one, since there are many lectures and presentation on the skull base and on the cavernous sinus. Professor Dellings, somebody came with the expression Dolenz Kawase approach. Somebody tried to combine these approaches, and they have published actually on this combined approach. how do you see the trim line or the value of combining the approach, and in which indication you might suggest this one? Because there's always some overlap between the two approaches, from anterior and from more subtemporal posterior.
When I'm asked about this posterior approach, I always have to mention Shiobara. Shiobara was an ENT surgeon in Tokyo, and he published his statoacoustic tumors operated via this approach through the apex of the pyramid, entering the inner auditory canal, and so on. So I read this, and I read the Glasscock's approach to the posterior loop of the carotid, and I said this area in between is a corridor. Together with Kawase, we were talking about this, and then we all profited from Shiobara. He was the first who used this approach. There were some trials before for the trigeminal neuralgia, Fraser, and so on. So, we all are standing on the shoulders of somebody else.
Yes, well, this is normal. That's true.
I wouldn't say we have to say this is mine, this is yours, this is yours. No, we all are pupils.
Oh, pupils, yeah, you are right. Anybody wants to give comment or questions?
Yes, Dr. Ayman.
Yeah. Victor from Mexico.
Dr. Vinco Doleng, Victor Hugo Perez from Mexico City.
Yes. Hello.
I remember that we talked about 3 years ago in China.
Yes.
And you told me the importance of preserving veins in all kinds of surgery, especially skull-based lesions. Can you tell us something about the veins in surgical anatomy in general? Thank you.
Thank you very much. This is a very important question. Once I was operating in Charlottesville, a tumor, or petroclival tumor, and a colleague once kept asking me, because I was entering through the pterional approach, I was working in the middle cranial fossa, and then going down to the posterior fossa. He said, "Can you show me the Petrus vein?" I said, "But come on, the Petrus vein is far away." But actually, he was right. Petrus vein is very close when you are transgressing the apex of the pyramid, and it is very important to preserve it, the Petrus vein and the superior Petrus sinus to remain patent. Otherwise, you will have problems from the posterior side, that is from the cerebellum. What I said about the veins, I think that to preserve the veins is to use the veins as a master who is staying behind us. If we are capable to preserve the veins, then we did a very gentle and nice surgery. And I am not so good as Jacques Marcos, who showed us wonderful reconstructing of a vein today. And I think this is an important an important topic. We have to discuss a lot about this. We can play about the veins. We can joke about them because the revenge do not come today. It will come 2 days later when we sacrifice too many veins and there is no way back. So we have to be aware of the importance of all the veins.
Thank you.
Imad, can I make a comment?
Yeah, please,
yeah.
Bill.
Thank you. So, you know, it was interesting. There was a conversation Vinko and Teet Matheson and myself had exactly about this several years ago in when we were at a meeting together. And it prompted us to think about, you know, how do we capture the experience of all the senior surgeons on the safety of veins? Because I think we've all experienced terrible outcomes from sacrificing a vein that we thought was innocuous. And so to that end, we put together a couple of surveys, and they've been published now, and you could look them up. Basically what we did is we looked at surgeons that had little experience and then surgeons who had a lot of experience. And we used the World Academy as the survey group. So these are leader neurosurgeons from all over the world, including Vinko. And we all put in our thoughts about how safe is it to sacrifice a vein. And what you find is that the more senior the surgeon is with the more experience, the more they respect the veins.
Thank you.
For exactly the reason that Vinko said. It doesn't come today, it comes in a few days, and it can be devastating. So I encourage the young people to look those survey studies up. They were just published in the last year. And it was really a discussion with Vinko and Teet and I that started that whole notion. And you can't quantify them. That's the problem. Arteries, it's easier, but you can't quantify the risk of sacrifice of an individual vein in a patient. So, yeah.
You're very right, Bill, very right, you know. And I would urge the younger neurosurgeons, when they are dealing with the parasagittal meningiomas in the parietal area, where are crucial veins entering the superior sagittal sinus, don't be ashamed to leave a little bit of the tumor close to the sagittal sinus in order to preserve the veins. If you will not do it, you might be punished with paraparesis, paraplegia of the patient.
Thank you. Very nice message, and I think a good lesson for future for the young generation. But I have to give credit about the venous system to our colleague Akira Hakuba, who has seen the problem with the venous system ahead of time. And I remember he was the one who called for the first meeting on venous system, because he recognized the trouble we can get from sacrificing these veins. All right, any other comments or statements?
Bill and Vinko,
yes.
We all have seen these problems. You see it rather frequently. If you have a long vein in AVM surgery, if it's thrombosed, then you have troubles. What do you do should this happen? Both Bill and Vinko.
Go ahead, Vinko.
I would like to be the second.
Yeah, I mean, go ahead, Vinko, please. Yeah.
You know, I've been discussing this with my friend Sandou from France. He did a lot of studies about these meningiomas, parasagittal, and repair of veins and of sagittal sinus. But I have to admit, I was not so successful in repairing the veins. This is different as to repair an artery, even the smallest one. So for that reason, I try to be less radical than to be too aggressive. But fortunately, I did not have big problems with this. but I don't know what I should do. If I, even when you sacrifice a trolar vein, this system is very variable. It's not always the same. You may sacrifice a vein, but you will have a paresis or serious symptoms and signs. The other time you will not have it. So preserving the vein, this is the only message I can convey.
Prevention is always better and easier, The last time I've seen this, that was an AVM case, and we ended up with a decompression. Everything ended up well, but just the large bony decompression. But otherwise, I do not know about anything. Bill, do you?
Yeah, you're right. You're right.
Yeah, I mean, I agree. It's so variable, Vladimir. And with pathology, it can be even more difficult to predict. And I think that's part of the problem. I remember seeing a video, Imad mentioned Hakuba, who was a brilliant guy. You remember him taking out the sagittal sinus and reanastomosing, putting a saphenous vein in and reanastomosing all the bridging veins to this. I mean, wild. I mean, really, but with radiosurgery now, we don't need to do that type of thing, I don't think. But I will tell you where I've been burned, Imad and Vinko and Vladimir, is that I've been burned around the region of the cavernous sinus and the petrous bone. And what happens, I think, is that you have these meningiomas that occlude some of the normal venous drainage. So the anastomosis between the petrosal vein and the petrosal sinus and the sphenocavernos sinus. And then it makes it very, very risky to even sacrifice any vein because you don't know where the collateral flow is predominant. And so, I've been thinking about ways that we could try to predict that, but it's so variable and each tumor is different, as you know. So preserve veins. That's what I agree completely, is just preserve the veins. Every one you can, try to work around it. And even just taking a petrosal vein, we used to say that you could take it with impunity, but I don't believe that because I've had bad experience. And I think, if you live long enough, you'll have bad experience with those kinds of things. And so just be very careful. I agree.
They say 17% of complications with the dendy vein, but in many cases of petroclival or superior petrosal sinus meningiomas, the sinus is occluded.
Yeah.
Then you would feel it's safe to cut the vein, but it would mean to do angio before surgery, and I do not know if anyone is doing that.
Oh yeah.
So
we do rarely.
Could I chime in? I actually think, especially for the youngest learning to operate in this particular area, a pre-surgical CTV is a helpful study to get a better idea about the extent of collateral flow. And as you said, Bill, leaving a piece of tumor behind that then is treated with radiosurgery is sometimes really the safest way, and it's all about quality of life in the end.
Right.
No doubt.
I want to add one more thing, talking about the parasagittal and falcine meningioma, especially parasagittal. It's amazing how much you can dissect these veins that people used to immediately coagulate them and cut. But they can dissect the long course, this arachnoid, and it gives some mobility of these veins to be away from your field during the resection. So don't jump immediately with the coagulation and cut. I think, Vinko, you want to say something?
Yes, I just wanted to say that Melis, I discussed with Leonard Melis, and he said any tumor at the posterior part of the temporal lobe and the drainage and attachment to the transverse sinus, he was always testing what happens. So he put the clip on the transverse sinus because he didn't know, because sometimes there was no angiography and venography prior to surgery. He didn't know how much compensate the other sinus. So you may profit from direct testing of some veins, how before you are too close or before it is too late?
All right, I think all of us must be tired after 4 hours webinar, unless you want to continue some more discussion. I keep it up to you. I don't want to be the one who conclude our beautiful neuroanatomy webinar. But if there is no question, and I'd like to thank everybody for being with us and accepting the invitation without hesitancy. We look for your presence in the future webinars. And I'd like Professor Vladimir, he was stuck this morning or this afternoon with the surgery, I think in the anterior clinoid. But as he promised, he joined us if he wants to give some comment on the conclusion remark.
Gladly. I missed almost nothing because I came when Vinko started, so I was nearly on time. There was excellent lectures, all of them. And if there should be some conclusion from me, it would be the invitation for tomorrow, because I hope that we shall have the top quality lectures again. So do please all join us tomorrow at 2 p.m. Central European time. Bill, it's early morning for you. Kazadi, are you in Zimbabwe or in Belgium?
I am on the planet Earth.
Yeah, Atul, it's late.
I'm in Zimbabwe. I'm in Zimbabwe.
In the afternoon, isn't it?
I'm in Harare, Zimbabwe.
You've been in Harare. Good. Yeah. So it's not a big difference. So Victor and Imad, do take over now.
All right. I think Dr. Kobayashi, I don't know, is he still with us? Professor Kobayashi? I think it's already midnight in Japan. So ready for sleep. Yesterday, I'm hearing somebody? No. All right. Well, thank you very much again.
Night in Japan.
Okay. Okay, Aipe, it's too late for you as well. So, guys, thank you very much for everybody, and hope to see you again. And tomorrow is very important. It's the same subject on neuroanatomy and the achievement of Professor Albert Roton. Thank you.
Thank you very much.
Thank you
very much.
Bye.
Thank you very much, Imad. Thank you.
Bye-bye. Bye-bye.
Bye-bye.
Bye, everyone.
Bye-bye.
Aiken.
Thank you, guys. Good night.
Good night.
Bye-bye.
Good night, everybody.
Night.
Dr. Kohn with us. Bye-bye. Atul.
Bye-bye. Bye-bye.
Bye, Atul.
Bye,
Bye,
guys.
Atul. Bye-bye.
Bye.
Bye.
How are you, Vladimir?
Good, thank you.
Pablo.
See you tomorrow.
Is your country open now? Is your country open now for my student to come? Mostly. Excellent.
Yes.
We'll contact you again.
Come to visit me.